Sir, we are in live. Good to go.
Mr. Javed? I think Mr. Javed, can you unmute? Durai?
Sir, 1 minute.
Yeah, sure.
Yeah, good evening, everyone. On behalf of INTAS and on my personal behalf, I would like to welcome you all for this wonderful webinar titled Multidisciplinary Approach in Osteoporosis today. You all are aware that osteoporosis is a very debilitating disease. 1 out of 3 women and 1 out of 5 men above the age of 50 will sustain a fragility fracture in their lifetime. The impact of this is so high that you could see almost 30 million Indians are affected with this debilitating disease. And though there has been so much of medical advancement that has happened in this field, still, I would say every program, there is something definitely new to learn as far as the medical management of osteoporosis. And today, in fact, going in line with that, we have organized this program for you, which is Osteoporosis Multidisciplinary Approach. And we have lined up some wonderful speakers and panelists who can throw more light on how we can improvise on the medical management of osteoporosis. I hope you all are fine, safe and healthy during these challenging times of pandemic and the new normal, which is what we are in today. With these brief words of warm welcome, I would like to hand over the session to Dr. Amit Rastogi, sir, who is a consultant endocrinologist, RK Endocrine Center, Meerut, UP, to take this proceedings further. Over to Dr. Amit, sir.
Thank you, Mr. Javed. At the outset, it's my pleasure to invite all the delegates for today's webinar, which is a multidisciplinary approach to osteoporosis. Mr. Javed has given you the overall burden of the disease in the community. What we see is just the tip of iceberg. And to have a holistic view of the entire problem, we have galaxy of speakers today with us from different fraternities. We have endocrinologists, we have rheumatologist, we have gynecologist, and also we have orthopedician to give his own view to complete the entire circle of management of osteoporosis. And it's indeed a pleasure that this program is being done under the aegis of WISDEN, which is World Integrated Society for Diabetes, Endocrine and Nutrition, along with AHILIA Endocrine Academic Forum. We have joined hands together to strengthen our approach to management of osteoporosis. Friends, it's indeed an honor for me to introduce today's moderator, a dear friend, a great academician, and an astute clinician, Dr. Saket Kant, who hails from Rohini, Delhi, who is working as a consultant endocrinologist and diabetologist in various forums like Sri Balaji Action Medical Institute, Max Super Specialty Hospital. He did his fellowship from the great prestigious Institute of Medical Sciences from BHU, and hope you have a great academic feast. I hand over the proceedings to Dr. Saket. Over to you.
No. Dr. Saket, you have to unmute. You are muted.
All right. Thank you very much. So my slide is visible right now.
Yes, it is visible now.
Yes, sir.
All right. So it's a pleasure to invite Dr. Padmanabha Shenoy, MBBS, MD, DM Rheumatology, who is a medical director for Center for Arthritis and Rheumatism Care Clinic at Cochin, to deliver his talk on glucocorticoid-induced osteoporosis. We'll take his questions after the talk itself. Then we'll have the second talk and the questions after that. After the third talk, we'll take the integrated questions with the panelists and the speakers, whosoever is available at that time. So I invite Dr. Padmanabha Shenoy to talk on glucocorticoid-induced osteoporosis.
Hope my slide is visible. Am I
Yes,
audible?
yes.
Yes, sir.
Perfect.
Yes, sir.
Thank you, Prem and Sanket, for this meeting, and I would like to thank Intas also for organizing this meeting. And as all of us know, osteoporosis requires an integrated approach, and a lot of dimensions to it. And it's a must that we go into this integrated kind of approach in treating osteoporosis. I will be speaking on treatment of steroid-induced osteoporosis. As steroids are has been in the field, especially in rheumatology and also in a lot of other diseases like pulmonary diseases, where it is being used for a long term. When steroids were discovered by Hench way back 50 years back, it was 70 years back initially. He was given Nobel Prize, and people thought he's going to cure rheumatoid arthritis. But people started using more and more steroids, and rheumatoid arthritis patients started fracturing and dying. Hence the saying, steroid make the patient rheumatoid arthritis walk faster to their grave. So steroids has caused a lot of problems, and one of the major induced problems of steroid overdosage is osteoporosis. Yeah. So if you look at the risk of vertebral and non-vertebral fractures within within 1 year of corticosteroid therapy, what people think is that steroids, if you use for very long time, we develop fracture. As you can see here, this is non-vertebral fracture, this is vertebral fracture. Within 1 year of therapy, the chance of fracture increases dramatically from baseline, especially when you use a dose more than 7.5 milligram per day. So what does it say? It is not that fracture happens after 4 years or 5 years or 6 years. Onset of fracture is rapid after starting corticosteroid therapy. That is one of the first things we should realize. And more importantly, the onset of bone loss is rapid within first month of starting therapy and slows down after 1 year. So when does the maximum damage happen? During the initial year of steroid therapy. And that is the time we need to address that. And what are the things which affect the fracture risk in corticosteroids? As you can see here, steroid dose can be divided into low dose, high dose, medium dose and high dose. Low dose means usually less than 7.55 milligram. Medium dose means 7.5 to 20 milligram, and high dose means usually more than 20 milligram. Low dose is usually not associated with, there's a meta-analysis which was published in Rheumatology Oxford in 2000. They have taken a huge number of patients, around 1.5 to 2 lakh patients they have analyzed. As you can see here, the medium and high dose is definitely associated with a increased incidence of the non-vertebral and vertebral fracture, and that too vertebral fracture. If you can see here, the odds ratio is 1.54 here, and in the high dose corticosteroid group, the ratio is 2.83. It is 2.83 times. So it's quite high. And second thing, again, coming back to the same point, if you look at the daily corticosteroid dose, the daily corticosteroid dose goes high and high, the risk of fracture increases exponentially, especially after a dose of 15 milligram. If it is less than 5 milligram, 4 milligram, the risk is much less. But if 15 milligram, 20 milligram, the risk exponentially rises, as you can see here. And excess fracture risk is 20% at less than 5 milligram per day prednisolone, while it is at 20 milligram, it is around 60% higher risk. And if you look at the cumulative dose, is the daily dose, if you give 5 milligram or 2.5 milligram for a very, very long time, is it not harmful? Yes, that also can be harmful, because what is important is the cumulative dose. As the cumulative dose increases, the chance of fracture increases again. And so not only the daily dose is important, cumulative corticosteroid dose is also equally important, because as you can see from this, the cumulative dose increases from 0 to 60, the BMD DEXA's bone mineral density decreases dramatically. So the correlation is inverse. It's again showing this almost the similar thing, but this is a cumulative corticosteroid dose, and this is the daily corticosteroid and cumulative corticosteroid dose. Both are equally important, but more important is daily dose than the cumulative dose. So if you give a higher dose, for example, 20 milligram or 25 milligram for 1 to 2 to 3 months, the chance of fracture is much higher than giving 2 milligram or 3 milligram steroid for 1 year. Although both of them have taken the same cumulative dose, if the daily dose is higher, that poses higher risk. And if you use the past corticosteroids, whenever somebody has used a corticosteroid, if you can see here, without BMD and with BMD, the risk is higher. So even if you've taken steroids any time in the past for a significant amount of duration of your past life, then you can see that the chance of fracture is higher. And this fracture risk, as all of us know, the effect of steroid on bones may not directly reflected in the decrease in the DEXA. So it is beyond DEXA, and it's higher than DEXA. So some people ask, I have stopped steroids, what happens to my fracture risk? This clearly shows after cessation of steroids, the risk comes down. When you are taking steroids, you have a risk of 1.5 or 1.6 relative risk. But after that, what happens? The relative risk comes down, and reaches around 1.2. But usually it becomes normal. So the risk is slightly higher. But definitely after stoppage of steroids, the risk decreases. So what did I tell you? If somebody is on long-term corticosteroid therapy, fracture can happen in 30 to 40, 50% of patients. And the rapid bone loss is very early. So the fracture risk increases even within 3 to 6 months. And usually loss of spine and hip BMD correlates with cumulative dose. Although the cumulative dose is important, but what is more important is daily dose. If you give a higher daily dose, the fracture risk increases exponentially, especially after 15 milligram of steroids. And it is associated with fracture risk is associated with both current and past use of corticosteroids. So this is one of the, I thought I will just brush up, tell you how the steroid caused the entire stuff. All of you know that the WNT pathway is one of the most important pathway in stimulating the osteoblast to form the bone. And there are two inhibitors of WNT pathway. One is DKK1 and sclerostin. And so what the steroid do is it increases DKK1 and also it increases the sclerostin, while it decreases the downstream molecule of beta-catenin and osteoprotectin. This beta-catenin and osteoprotectin are inhibitors of osteoclast. So by inhibiting WNT pathway, the bone formation decreases, while by inhibiting the beta-catenin and osteoprotectin pathway, the bone resorption increases. Similarly, glucocorticoids also increases rank ligand and MCSF, which will again cause increased osteoclast, that this osteoclast will eat away the bone, while steroids will decrease WNT pathway and caspase, and also activates caspase 3. So what happens? Because caspase 3 we know is an apoptotic molecule, so osteocytes will die. So the osteocytes will die, osteoblasts will die. So there is decreased bone formation, while osteoclast will be more active. So there will be early transient increased bone resorption, which is responsible for early fracture, while in long term there will be decreased osteoblast and osteocytosis. Apart from this I told you already, the effects on the bone I told you already. Apart from the effect of bone, this also has effect of neuroendocrine system, decreases the steroid, decreases the calcium absorption, increases the renal excretion of calcium, leading on to negative calcium balance. But what is very important, what we don't realize is that steroids usually causes the muscles to degenerate. So what will happen? There will be steroid-induced myopathy. Steroid-induced myopathy will lead on to increased falls and increased fracture. This is one of the things I think which is hugely unaddressed. This steroid myopathy is causing increasing number of fractures. So this is what I was telling till now, that steroids can definitely increase fracture. But as all of you know, rheumatoid arthritis or lupus, all the inflammatory conditions because of inflammatory cytokines, already have a increased bone loss going on there. Why does it happen? Because it increases the osteoclast and it decreases the osteoblast. And steroids, by controlling the inflammatory disease, for example, rheumatoid arthritis increases the osteoporosis by certain percentage. By controlling rheumatoid arthritis, steroids will decrease the risk. So there's always has to be a balance going on. So by controlling rheumatoid arthritis, steroids slightly improve the BMD, but most of the time, in long term, if you give steroids, it will be more harmful than beneficial. So what are the risk factors for glucocorticoid-induced osteoporosis? Most important risk factor, as all of us know, is advanced age, low body mass index. These are applicable for general osteoporosis also. I'm sure Dr. Prem is going to cover this. And so I don't want to go into details of that. But I again want to stress the same thing. Higher daily dosage is extremely important. Also, the cumulative dose is extremely important. So whom to treat? So first and foremost is to prevention and treatment. I will first see how much I have told you the if you use steroids, the risk of fracture is much, much higher. But there are a lot of guidelines, more than 5, 6, all the societies has come out with guidelines. But if you look at the data, it is very disappointing. This what it shows is, this shows the achieved within 6 months, and this shows what has happened in the patients, how many patients of osteoporosis are getting BMD done, how many of them are getting treated, and how many of them are getting tested and treated. If you look at the BMD, only less than 5% of the people get a BMD done. And if you look at the last 15, 20 years data, this is around 2008. After that also the results are almost similar. 2015 also 5 to 10% only get the BMD in the first 6 months. And after that also, the chance of getting a treatment also is even less, around 15 to 20%. Although from 1998, the amount of people getting some kind of anti-osteoporotic treatment like bisphosphonates or teriparatide has increased, but the testing is very less, and also only 1/3 or 1/4 of them get the appropriate treatment. So there is a lot of, even if it's males and females, young and old, and no fracture, prior fracture, all of them. If you look at the prior fracture, that is very, very alarming. If you look at just the last one, if somebody has fractured already, more than 70% of them still don't get a DEXA done. So that is extremely worrying. Why is it worrying? Because once you have a fracture, your bone is already weak, and chance that you are again going to fracture is very high. And most of them, 70% of them, don't get any kind of anti-osteoporotic treatment despite fracturing. So that's a very worrying thing, and that is that shows that we need to increase the awareness of the osteoporosis in community and among physicians too. FRAC score, again, Dr. Prem is going to talk about this in detail, so I don't want to spend time on that. Just coming back to the management of glucocorticoid-induced osteoporosis, first and foremost is use less amount of steroids. The problem with steroids, that has been told in rheumatology community, last 10 to 15 years, this has been the thrust. In lupus, in rheumatoid, in myositis, what is told now is, whatever dose you want to give steroids in your mind, just give the half the dose. And there is enough and more data that lower the dose also work. The pulsing is not in fashion now. Pulsing is going down the line, and daily dose of steroids more than 0.5 mg per kg is now less and less and less. If you give less amount of steroids, less amount of cumulative dose will happen. And also always give good nutrition, do regular weight bearing exercises. This will help the bone to prevent the bone from losing its mass. First and foremost is vitamin D and prevention of falls. So if you look at the this meta-analysis, as you can see here, the vitamin D alone or calcium alone, this is vitamin D alone. As you can see the forest plot, there is no effect. If you give calcium versus controls, again, there is no effect. But if you give vitamin D plus calcium, there is definitely a decrease in the number of falls. So vitamin D plus calcium will have a modest effect on prevention of falls. Vitamin D and calcium already, we know that it improves the bone health to a significant extent. But vitamin D plus calcium is definitely superior. As you can see here, the forest plot, definitely vitamin D plus calcium decreases the fracture risk when compared to calcium alone. So vitamin D has to be given, calcium has to be given. There is no doubt about it. Every patient who is on steroid has to be given supplementary vitamin D and calcium. But is vitamin D alone is effective? No. If you give some kind of osteoporosis therapy, this is basically the bisphosphonates or calcitonin, fluoride, etc., etc. If you take the pooled effect also, individual effect also, you can see here, bisphosphonate and fluoride definitely have much more effective than vitamin D alone. So those patients who require a higher amount of therapy, higher dose of steroids, this will come to a couple of slides later, has to be given osteoporotic therapy. So regarding calcium and vitamin D supplementation, they're extremely important. Vitamin D improves the muscular strength, and vitamin D plus calcium, as I told you, improves the decreases the risk of fall, and also it increases the bone strength. And active vitamin D is not as potent as bisphosphonates. So we have to give every patient, again stressing the same thing, any patient on steroids has to be given calcium plus vitamin D, whatever may be the dose of steroids they are on. So with what? Apart from calcium and vitamin D, they may require something else. What? Some of them can be, so there have been the data for last 20-25 years. This was one of the landmark trials which was published in New England Journal way back in 1998. They were comparing placebo versus alendronate. As you can see here, the alendronate arm had a higher BMD. This is alendronate arm. This is the placebo arm. Placebo arm had around 48 weeks. As you can see here, there is significant loss of bone BMD. While, as you can see here, both the alendronate arm had improvement in BMD. So in other words, if you give patients alendronate, it preserves the bone strength. Same, this is the 2-year data of the same, which was published in 2001 in Arthritis and Rheumatism. Again, the same thing. Those who are on alendronate do much better than those who are on placebo. And not only that, when the 2-year data came, as you can see here, this is vertebral fracture, year 1 and year 2. And as you can see here very clearly, in alendronate arm, there was only 0.7, only one fracture, while in placebo, there was 6% fractures. And in the year 2, the effect was much more pronounced. You can see here, 59 patients, 3 out of 59 patients fractured in placebo arm, while in alendronate arm, none of them fractured. What does it tell us? It tells us that alendronate not only improves the bone mineral density, but also prevents vertebral fractures. The same data with the residronate also. Residronate, it was published again in around 1999 in Arthritis Rheumatism, where they could show that there was 70% fracture reduction, especially in the vertebral fractures. You can see here in the residronate arm when compared to the placebo arm. So definitely they are useful. There is no doubt that bisphosphonates are extremely useful therapy in the management of steroid-induced osteoporosis. Then the landmark trial, the Horizon trial in Lancet, which was published in 10 years back, where they compared two bisphosphonates, zoledronic acid versus residronate. As you can see here, zoledronate, the improvement in BMD was much better, both in the lumbar spine and femoral neck. The improvement was much, much better. So what the conclusion was, zoledronic was non-inferior and superior to residronate in increasing lumbar spine BMD in the prevention of steroid-induced osteoporosis. This is basically the biomarkers, bone absorption markers, but it also showed the same thing, that zoledronic acid caused rapid and substantial decrease in bone turnover than residronate. But whatever recommendation currently is that IV therapies are going out of fashion, especially in rheumatology community, because of a simple reason that the amount of the difficulty to administer, the amount of increase in pain sometimes happens, but always zoledronic acid assures compliance. That's what we have seen. But those patients who are very compliant, they can be maintained on alendronate or anything else also. But in my practice also, initially I used to use a lot of zoledronic acid. Now the amount of zoledronic acid I have come down, and alendronate and ibatonate has definitely gone up much higher. Coming back to teriparatide versus alendronate, this was teriparatide PTH analog, recombinant PTH. As you can see, this is again New England Journal paper, which was published in 2007. As you can see here, the teriparatide is definitely more effective when compared to alendronate. At the end of 1.5 years, teriparatide is much more effective when compared to alendronate, not only in lumbar spine, also in the total hip. And also it decreases the bone turnover markers much better. And not only that, it also we can see here very clearly the vertebral fractures. The p-value is highly significant. Here 6.1% in alendronate, while in teriparatide arm there was only 0.6%. And non-vertebral fracture there was no significant decrease, but the decrease was mainly in the vertebral fractures. This was their long-term data. Teriparatide, again, the almost similar time, the arthritis rheumatism also published the study, where again they showed the same thing, teriparatide versus alendronate. This is teriparatide, this is alendronate. You can see the clear-cut difference. But again, showing the same results at New England Journal, reproducing the same results, that radiographic vertebral fractures were much less in those patients who are teriparatide when compared to those patients on alendronate. So teriparatide is definitely much more effective, but we know teriparatide has been subcutaneous, the cost of therapy is higher, and the compliance is not as great because of the various factors in our subcontinent. But teriparatide is definitely effective. Now, coming to the next step, denosumab versus risedronate. If you see the denosumab is anti-rank ligand antibody. If you see the those patients who are continuing glucocorticoids or those who have stopped glucocorticoids and those who are hip BMD or femoral neck BMD, as we can see here, the denosumab was much better when compared to risedronate. So denosumab and teriparatide, which are newer therapies, are much better when compared to the bisphosphonate. This is the fracture risk, or they were almost similar. This is the one of the latest paper which was published a couple of months back in Bond Reports when compared to the denosumab versus teriparatide. As you can see here, denosumab at the initial 6 months and 12 months, there was a difference there. Teriparatide was much better than denosumab. But at the end of 24 months, there was no much difference between the denosumab and teriparatide. So teriparatide improves the bone density faster, but at the end of 1 year or 2 years, the difference is not maintained. And especially at the end of 2 years, the difference is not maintained. So denosumab, and there are people who have started combining denosumab and teriparatide. So whom to treat with osteoporotic medications? Sorry. Hello? My slide got closed.
Slide got. You can share again.
Yeah, I'm sharing. I'm sorry.
Yeah.
One second. Can you see? Can you see?
It's coming.
Yeah,
It's
sir.
coming.
Now
Yes,
it's
yes.
okay, sir.
Yes, it now it's.
So, whom to treat with osteoporotic medication? This is of all the recommendations. I think ACR recommendation I find very useful. 2017 recommendation. This is the nutshell, made very simple. Just divided to 2 groups: more than 40 years and less than 40 years. Those who are more than 40 years, if they have any osteoporotic fracture or steroid dose is more than 30 milligram per day, or T-score is minus 2.5, or look at the FRAC score without BMD. If major osteoporotic fracture risk is more than 10% and hip fracture is more than 1%, you treat them. So any of this is enough. If you have T-score less than minus 2.5 or steroid dose more than 30 mg, or anybody who has an osteoporotic fracture will require a treatment. If less than 40 years, history of osteoporotic fracture or steroid dose more than 30 mg again, but if you apart from, here T-score is replaced by Z score. And if Z score is minus 3 or loss of bone mass is more than 10% and the patient is on steroid more than 7.5 mg per day, then also you need to treat. So above 40 years, your threshold is much, much lower. And another very important thing I want to tell you is steroid modified, always FRAC score has to be modified for the steroid. And these are suggestions that, for example, in the major osteoporotic fracture, the multiplication is by 1.15, and in hip fracture, the multiplication is by 1.2. For example, if you calculate the FRAC score, the FRAC score comes as 2. Then if the patient is on steroid, you multiply it by 1.2 and you get a score of 2.4, which is very high. So that's how you want to modify the FRAC score and decide whether the patient has to be treated or not. And give calcium and vitamin D to everyone. And this treatment is over and above that. So choice of treatment, the first and foremost treatment is oral bisphosphonates. That's what the recommendation says. And if the oral bisphosphonates are contraindicated and patient is not willing, has some contraindication for that, give for IV bisphosphonate. If they are also not, there is a contraindication for both the things like oral and IV bisphosphonate, like a patient has high risk for already has a atypical fracture, or they are unable to tolerate and they have influenza-like symptoms after giving bisphosphonate, then you go for teriparatide. And if the patient is not tolerating any of this, then you go for denosumab, because this is the ACR recommendation. But when should you follow up the patient? If the patient is not, if somebody is on steroids and you have not started on any anti-osteoporotic therapy, you have to do a repeat BMD after 1 to 3 years and again reassess the fracture risk. And if the patient has stopped steroids, you can consider stopping anti-osteoporotic therapy only after the patient is in the low risk group. So keep on, the most important thing is to calculate the FRAC score and assess the risk factors and then decide whether to continue or not. So I had till now, I want to emphasize one point. Till now I have been speaking on early treatment of anti-osteoporotic, early treatment of glucocorticoid-induced osteoporosis. Just I will show you one case of a 35-year-old male. So he's a young male who is a non-case of lupus nephritis. So in lupus nephritis, we induced with rituximab and maintained them on mycophenolate. Within 6 months of therapy, his steroid dose was rapidly tapered to 2.5 milligram per day. Because he was 35 years and we were planning to stop steroids in 3 to 6 months, we decided not to give him bisphosphonate. And because of the pill load, there has been 8 or 9 tablets he has already been taken. So we didn't give him, and his creatinine was slightly on the higher side. So we didn't start him on bisphosphonate. And he one day presented with acute onset low backache. You can see here what is there. There has been, and he was wheelchair bound. He was not able to move, in severe pain. And there were already 1, 2, 3, 4, 5, 6 vertebrae have been fractured. This happened within 6 months. So what do you do now? So till now I have been telling, if somebody has an osteoporotic fracture, somebody is on steroids, the first and foremost choice is bisphosphonate. This is what data says. But if somebody has fractured already and is in severe pain, most of the time you need to improve the bone mineral density very fast. So in these cases, there is a school of thought that you have to give a teriparatide and denosumab, which would improve the bone mineral density very fast. And this patient can be either put on denosumab maintenance or bisphosphonate maintenance. This is for food for thought. Just to tell you that treatment in case of patients who are fracturing on steroids, the treatment may be different than prevention of fractures. So somebody already has fractured, that indicates that their bone mineral density is already much lower. And as I told you earlier, teriparatide and denosumab pick up the bone mineral density much faster than bisphosphonate. So what are the take-home message? 1, glucocorticoids leads to early and rapid bone loss. Second, usually it happens, there is a very early, during the first year itself. To prevent that, the first and foremost thing is use least amount of steroids and stop steroids as early as possible. And early intervention is extremely important. Everybody needs to be on calcium and vitamin D, and general lifestyle modification has to be there. And other patients, those who are on steroids during the initial months, more than 6 months, start them on bisphosphonate. And again, emphasizing the same thing, if somebody has already fractured, the chance that they will have another fracture is higher. In those patients, I think, although there is not much trial evidence, definitely teriparatide and denosumab are extremely effective, not only in improving their functional capacities in 1 month, and I think they are more effective in controlling the pain too. And they bring back the patient to normal life much earlier. Thank you for patient listening.
All right.
I had actually prepared this talk telling that I'll be presenting last. So Prem will be explaining teriparatide and denosumab, etc. Because of some other meeting, I could have to go early. So sorry for that.
So probably we'll be taking your questions right now, and then probably we'll let you go. So the questions that we have for you are, first of all, you said that dose and duration of steroids can lead to increased osteoporosis fracture risk. So what do you suggest a drug holiday for some of your patients who basically are well controlled? For example, they can be put on a drug holiday for some time, steroids can go away for some time, and they can resume steroids after that?
Yeah, steroids, basically, in rheumatology practice now, what is the, whichever disease it is, be it rheumatoid, lupus, our steroid dose has remarkably come down. Why this has happened over the last 20 years is, for example, I will take the example of lupus. There's a cohort called Toronto cohort. there's a huge cohort of more than 2,000 patients who have been treated of lupus, have been followed up for 20, 25, 30 years. Once they analyzed their patients' data after 10 years, what they found was there is more damage due to steroids than disease. Most of them are living longer, 95%, 98%, 10-year survival, but they have cataract, they have avascular necrosis, they have osteoporotic fracture, etc., etc., etc. So in rheumatoid arthritis patients or lupus patients, longer the duration of steroid usage, it is basically shows that your other immunosuppressants are not optimally managed. If you optimally manage your other disease-modifying anti-rheumatoid drugs, be it biologics, be it anything else, your chance of that patient is on steroids for a very long time, more than 6 months or 1 year, is less than 10%. 90% of the patients definitely can be stopped with steroids.
So you were talking about prophylaxis versus treatment of osteoporosis for the long-term steroid therapy. So how do you choose which patient to be given a prophylactic dose and which patient would go in for treatment of osteoporosis after you've planned a long-term steroid therapy? You'll have to get a BMD for everyone in that case?
See, BMD, what I recommend is everybody has to be done a BMD in 6 months to 1 year, especially more than 40 years. But if that is not possible, at least calculate the FRAC score. The problem is majority of clinicians fail to understand that FRAC score is calculating FAST score, even if without BMD, gives you some idea that how much risk is this patient have. And as all of us know, rheumatoid arthritis is one of the risk factors for gives a separate score in FRAC score. How to choose? As I told you, if somebody has already fractured, I usually use teriparatide or denosumab, which are fast acting. If somebody has not fractured, we usually give bisphosphonates.
So, for example, for prophylaxis, you can always increase, BMD by giving anabolic agents first. Then you can start your steroid therapy. And when you're planning treatment of osteoporosis for GIOP, because osteoclast activation is more predominant in GIOP as compared to the apoptosis of osteoblast. So probably drugs acting on osteoclast would be more effective in treatment of glucocorticoid-induced osteoporosis. Prophylaxis, you can give anabolic agents and increase the bone mass. Then you can give probably
stabilize it. If somebody's DEXA is already -4 or -3.5, you are planning them steroids. I think teriparatide initially and maintaining with bisphosphonates will be a good idea. Very true.
So myopathy, very interesting point. Increased risk of falls also. Vitamin D is one of them that can cause proximal myopathy also. You stressed upon calcium vitamin D supplementation. So what else? Because the fibers change, fiber 1, fiber 2 in the muscle change because of steroid therapy. So can anything be done for that you can decrease the conversion of fiber 1 to fiber 2 or something like that can decrease myopathy?
Basically, again, coming back to the same thing, never use more than 5.5 mg per kg of oral steroids. That is the most important thing, I think. So use the lesser amount of steroids, which will give you less amount of steroid myopathy.
If you look at the physiology text, they always say steroids decrease 1-alpha hydroxylation. So that would mean that if you even give vitamin D, that would decrease 125 hydrox active form calcitriol will decrease. So do you think calcitriol will do more benefit than vitamin D for patients who are basically, they have adequate amount of vitamin D? So probably 1-alpha hydroxylation gone with steroid therapy, 125 will make more sense?
Really speaking, theoretically, yes, in biochemistry, it's true, but there is no clinical evidence to suggest that. So, and I find that if you give once a month vitamin D or once in 3 weeks of vitamin D, most of the compliance is much better. Already they are 6 drugs or 7 drugs. Adding one more tablet, what will they do is they will stop mycophenolate. Then you are in soup. For maybe 0.5% or 0.2% reduction, you are going to lose a much bigger chunk there. So trying to decrease the pill load is the key.
So dose frequency administration, for example, you're just talking about osteoporosis. These patients have increased risk of hypertension, also suppression of the HPA axis, AVN, pancreatitis, also hypertriglyceridemia, also. So how do you plan, holistic workup or follow-up for these patients to have minimum? Because probably after pulmonologist, you are the rheumatologists are the guys who will be using steroids the most. So how do you plan to follow up these patients for all the other adverse effect that the patient can have apart from osteoporosis?
The question is other side effects of steroids. See, first and foremost, again I am telling you the same thing. First and foremost is to use the least amount of steroid to bring down the steroids to less than 5 milligram per day within 6 months or 5 months and stop them within 1 year. But most of the time, today also in OPD, I saw one patient who is on steroids for 15 years or 20 years on 10 milligram of isoflurane. In those kind of patients, it's impossible to stop. You have to make, because they will have adenosine crisis. So they will have, these are the kind of patients we may tend to maintain them on very low dose of steroids. So monitoring of other adverse events, we know steroids causes increased metabolic syndrome, it causes increased risk of infections. So we vaccinate them and check their lipid profiles, look at them, how the lipid profiles are there, promote their increased activity, and do that kind of stuff.
All right, I guess we have no more questions for you, and we'll move on to the next talk. Thank you very much for the very interesting presentation.
Thank you.
I'll be introducing the panelists and the rest of the speakers. We're going to stay with us for the final discussion also. Our first expert panelist is Dr. Veena Kumari. She is an MBBS MD Obs-Gynae additional professor at Government Medical College, Kottayam. The second expert panelist is Dr. Sri Ganesh Shankar Chatanaran. He's MBBS DNB Orthopedics Fellowship in Joint Replacement, Consultant Orthopedic Surgeon at Ahilya Diabetes Hospital, Palakkad. Third expert panelist, Dr. Vivek Patel, is MBBS MD DM Endocrinology Consultant Endocrinologist at Ahmedabad. We already heard our rheumatologist. The next speaker is Dr. Arun Philip. He's MBBS MD DM Medical Oncology Associate Professor at Amrita Institute of Medical Sciences, Kochi. And this talk would be followed by Dr. Prem Narayan, MBBS MD DM Endocrinology Consultant and Head of Endocrinology and Diabetology at Ahilya Diabetes Hospital, Palakkad. So I invite Dr. Arun Philip for his talk, and we'll take his questions after that. And after that, Dr. Prem will deliver his lecture, and we'll take the final discussion with the panelist and the speaker after that. Dr. Arun Philip, please.
Thank you, Dr. Saket. I hope I'm audible.
Audible and visible.
Thank you. I'll just share my screen. Yeah, it's fine.
Perfect, perfect.
First of all, I'd like to thank Dr. Prem and the organizers of the meet for giving me this opportunity to interact with you. The talk I'm going to give today is on secondary osteoporosis and malignancy. So the talk will primarily be focused on aromatase inhibitor-induced bone loss, because that's the scenario that we very commonly encounter compared to the other areas of secondary osteoporosis and malignancy. Now, as an introduction, bone loss in malignancy is most often due to therapy. So it is per se not due to the malignancy, but usually due to therapy that we clinically encounter bone loss in our patients. The one example where you encounter bone loss as a result of malignancy per se is multiple myeloma and other plasma cell dyscrasias. Of course, there are a lot of patients with hematological malignancies who are on steroids, but usually they do not go on long-term steroids. The steroids are a short-term, management protocol in most of our malignancies. GnRH agonists also contribute to some amount of bone loss in many patients, especially prostate cancer patients and the patients of breast cancer. Many of these breast cancer patients are on GnRH agonists, especially if they are premenopausal, to bring down the levels of estrogen. So the most important aspect in our clinics that we usually commonly see in our clinics is aromatase inhibitor-induced bone loss. So there are various risk factors of osteoporosis in general, and also increased risk of fracture for cancer patients that has been seen in many studies. And one very important factor is, of course, if the patient is a case of breast cancer, aromatase inhibitor treatment is probably a major risk factor for osteoporosis and the risk of fracture due to osteoporosis. A BMDT score of less than minus 2.5, increasing age. Of course, I believe all these are common for all patients, not just malignancy patients. And use of oral corticosteroids more than 6 months. Prednisolone dose as low as 2.5 mg, is a risk for bone loss, and also increasing the risk of fracture. lower body mass index, family history of a hip fracture, personal history of a fracture above 50 years of age, and of course smoking and alcohol are also known to increase the risk of osteoporosis and fracture in our patients. So just a brief mention about multiple myeloma. Multiple myeloma is a very common hematological malignancy that we encounter, and we all know from our undergraduate days that it is one condition where there is a lot of bone loss involved and a lot of lytic lesions in various bones. We all remember the classical X-ray findings of the punched out skull lesions of myeloma, usually kept for exams also. So what happens in myeloma is basically it's a clonal proliferation of plasma cells. So there's a lot of atypical plasma cell collection in the bone marrow, and this is what finally leads to increased bone resorption and reduced bone formation. So in the cartoon above, the spaceship-like structures that you see are the bone marrow stromal cells, and these red ones, which looks like Pac-Man, are the osteoclast, and we also have the osteoblast in the picture. And there is in a patient with multiple myeloma, there is a lot of infiltration of these plasma cells into the marrow, and what happens is there's a lot of cytokine release from these abnormal or atypical plasma cells, or myeloma cells as they are called. Interleukin 6 and interleukin 7 are the major cytokines which are implicated in increasing the bone resorption and reducing bone formation. So it increases the rankle by these bone marrow stromal cells, and there's also increased degradation of the osteoprogerin. And what happens is the increased rankle OPG ratio leads to a differentiation of osteoclastic precursors, and this further increases the bone loss, and there is also decreased osteoblastogenesis, and finally results in osteoporosis. So as far as multiple myeloma is concerned, the use of bisphosphonates is critical in the treatment of multiple myeloma. We start the patient as soon as we diagnose multiple myeloma. If the patient has a lytic lesion, which almost 99% of these patients will, they are started on bisphosphonates right at diagnosis. So they are continued on monthly bisphosphonates at least for a period of 1 year. And many of these patients may receive bisphosphonates up to 2 years, as depending on their tolerance. Or after 1 year, many of them may receive a 3-monthly dose of bisphosphonates. So the maximum data is for monthly zoledronic acid. Of course, in many myeloma patients, renal functions are a big concern. We know that zoledronic acid is not indicated in patients who have a creatinine clearance of below 35 or 40. So many of our myeloma patients may present with renal failure as well. So some of them do not go on for zoledronic acid because of this reason. Denosumab, which is of course another option, which is safe in renal failure, is an option that can be used in such a subset of patients. So it is also seen that this zoledronic acid or bisphosphonates, when used in myeloma, offer some survival benefit as well. That has been proven in many studies. So it is known to interact with the bone marrow myeloma environment, and that is the bisphosphonates are supposed to play a kind of a good role in changing the biology of this the disease altogether. So that may be the reason why it improves survival, as seen in multiple studies. So with regards to the aromatase inhibitor therapy, I'd like to go on to a case discussion where this is basically a lady, 71-year-old postmenopausal lady, who was diagnosed with a case of carcinoma of the right breast in 2014, underwent the standard treatment, modified radical mastectomy. The post-op histopathology was an early stage breast cancer. She was ER/PR positive. So ER is the estrogen receptor, PR is the progesterone receptor. And when these patients have a tumor which is ER positive or PR positive, all these patients are candidates for adjuvant hormone therapy. Now, the hormone therapy that we commonly use in breast cancer in postmenopausal women is the aromatase inhibitor, either letrozole or anastrozole. So therapy for breast cancer who are estrogen receptor positive will go on letrozole or anastrozole for a period of 5 to 10 years. Now, she was also started on calcium and vitamin D supplements, as is the practice when you start letrozole. I also said that in the baseline DEXA was also done. The T-score was about -1.5 osteopenic range, and she was also started on 6-monthly bisphosphonates. She had an uneventful follow-up period until 2018, when she presented with a fracture in the neck of femur. That is after start acid once in 6 months for one. Now, when you have a patient presenting with fracture, a bone fracture, your first thought goes to whether it is a metastasis. Now, metastatic workup 6 weeks after fixation of this fracture was done with a PET-CT, and the PET-CT was negative. And so hence, when you have a PET-CT negative in a patient who has a fracture, the only thing that you go back and think is that probably she has secondary osteoporosis induced fracture, if it is not a pathological fracture. Now, if you look at the literature, aromatase inhibitors are the first line standard of care for patients who are ER/PR positive and who are postmenopausal or present with breast cancer. It leads to profound suppression of estrogen levels. Already postmenopausal status, estrogen levels are low, and when you inhibit aromatase, which inhibits the peripheral conversion of androgens to estrogen, you further bring down a drastic reduction in the levels of estrogen. Now, that is what we want in breast cancer. You want the estrogen levels to be low, because we know that estrogen may have a proliferative role in many of these breast cancer tumors. So concerns regarding the risk of fracture is very, very important when you start off aromatase inhibitor therapy. Baseline evaluation is usually recommended with a DEXA scan, and a pharmacological intervention is always required when you start the patient on anastrozole or letrozole. So if you look at the literature with regards to the use of aromatase inhibitor therapy, pharmacological therapy, what we commonly see is that most of these data are with respect to zoledronic acid. More than 90% of data for adjuvant bisphosphonates in breast cancer patients on aromatase inhibitor is with zoledronic acid. The other bisphosphonates. This is one particular study where more than 1,000 patients who were receiving adjuvant letrozole were randomized to either immediate or delayed start of zoledronic acid. Now, zoledronic acid that we use is 4 mg every 6 months, and earlier it used to be given for a period of 5 years. But now the recommendation states that it has to be given for at least 3 years. So 3 years is probably good enough for patients who are receiving adjuvant aromatase inhibitors as prophylaxis. Now, if you look at the study, this shows the change in the bone mineral density at in the postmenopausal cohort. That is the first one, and the other cohort is the recently postmenopausal set of women. And it was seen that in both these set of patients, the use of adjuvant zoledronic acid significantly reduced over the period of use over these 5 years. So it was statistically significant. If you look at the gray line, it is the set of the gray bar. It is a set of patients who received immediate adjuvant zoledronic acid, compared to the dark line, which is patients who have received delayed adjuvant zoledronic acid whenever an event occurs, either a skeletal related event or severe osteoporosis. Starting zoledronic acid delayed definitely does not work in favor as far as bone mineral density is concerned. So this was some of the earlier data with respect to zoledronic acid, and also there with time, lots and lots of data started coming up with in favor of zoledronic acid. And another particular study where more than 600 postmenopausal patients, again with hormone receptor positive breast cancer, were randomized to receive delayed or upfront zoledronic acid. When they saw the change in the bone mineral density at the lumbar spine and the total hip bone mineral density, both these factors, zoledronic acid significantly improved the bone mineral density over the period of treatment. So this is very recent data in premenopausal women who are on adjuvant endocrine therapy with either zoldronic, with either tamoxifen or with on anastrozole. So premenopausal patients, when they are put on anastrozole or letrozole, usually we also use GnRH agonists along with it, because you have to suppress the ovarian function, and then only these patients are to be put on anastrozole. So majority of these premenopausal patients go on tamoxifen. If not, another option is using OFS plus aromatase inhibitors. So in the premenopausal cohort, also now we have data that bisphosphonates, mainly zoldronic acid, improves the bone mineral density and is considered to be becoming a standard of care. Now, adjuvant bisphosphonate therapy in early breast cancer, there's this huge meta-analysis that included 18,000 women and with a median follow-up of close to 6 years. And this particular study looked at the breast cancer specific survival. Now, it was seen that patients who received the zoldronic acid had a 3.3% better survival at 10 years compared to those patients who were not on bisphosphonates. So the control arm did not receive bisphosphonates. So zoldronic acid, this landmark meta-analysis showed that bisphosphonates improves survival also in breast cancer patients who receive adjuvant aromatase inhibitors. Now, this trial led to guidelines recommending zoldronic acid for all metastatic breast cancer patients who were on aromatase inhibitors. Also, there is a lot of data coming up with regard to denosumab. Denosumab is a rank ligand inhibitor. There is this particular trial was from the Austrian Breast Cancer Consortium, where they showed that it is definitely superior to placebo as far as adjuvant therapy with the adjuvant therapy is concerned. So denosumab used at a dose of 60 mg subcutaneously every 6 months was the test arm, and the control arm did not only were on placebo. So the risk of fracture and skeletal related events were much better in the denosumab arm compared to the placebo arm. So with regards to direct comparison with zoldronic acid in breast cancer, there is no compelling evidence to say that it is superior. There is data to show that it is probably efficacious. But in a proportion of prostate cancer patients, it is proven that probably denosumab is better than zoldronic acid as far as delaying the skeletal-related event and other adverse events are concerned. So denosumab is definitely an option, which is at par with zoldronic acid, but we know that it is considerably more expensive. Generics are coming up, but still continues to be much more expensive compared to zoldronic acid. So this may be an option in patients who do not tolerate zoldronic acid or who are not candidates for bisphosphonates. So another the agent where although data is not much, some data is there with regards to the use of ibandronic acid or even alendronic acid. So ibandronic acid, the advantage is that it's oral. It's used at a dose of 150 mg monthly, and alendronate is used at a dose of 70 mg weekly. Very few patients are on these oral drugs as well when they are on adjuvant aromatase inhibitors, but a very small fraction, of course, patients who are not willing for IV injections. Some of these patients who develop infusion reactions with zoldronic acid, which is becoming very common nowadays. So some of these patients who are not candidates for zoldronic acid, who do not want IV therapy, go on to get oral ibandronate or alendronate. So what about tamoxifen? So tamoxifen is also an anti-estrogen which has a proven role as adjuvant therapy in breast cancer. It's usually used in premenopausal women, as I said already, but it may also work in postmenopausal women too. So tamoxifen basically inhibits the estrogen receptor. So why don't we use tamoxifen if we are so worried about the osteoporosis and the bone loss related to aromatase inhibitor? Now it was seen that we all know that most of these studies on breast cancer patients with on letrozole showed that there is a significant increase of risk of fractures in comparison to patients on tamoxifen. The risk of fracture is 7.5 versus 5. But the issue is that it's there's a lot of data which says that in patients who are postmenopausal, letrozole is definitely superior to tamoxifen as far as breast cancer specific survival is concerned. So it's a reality that AI-induced musculoskeletal syndrome is seen in about 10 to 20% of patients. So in our population, although there is not much of data with regards to AMMS, MSs, in our clinics we usually come across a lot of patients who develop a lot of bone and joint symptoms after starting aromatase inhibitors, usually after a period of 6 months to 1 year, and it's very, very difficult to treat. So many of these patients end in discontinuation of the aromatase inhibitors. So as I asked, why not use tamoxifen instead of AI? One, as I already said, the breast cancer specific recurrence and 10-year mortality may be better with aromatase inhibitor in comparison to tamoxifen. So that's a very compelling, data that drives you to use more of aromatase inhibitors than tamoxifen. And tamoxifen also has certain side effects like endometrial cancer and venous thrombosis. So those are also matters of concern. So in summary, in patients who are initiating aromatase inhibitors, a baseline DEXA of the hip and lumbar spine is recommended by most guidelines. But the fact is that irrespective of the DEXA scan results, we end up giving the patients bisphosphonates in the adjuvant setting because that has shown survival benefit. Now, the FRAX score, as already was mentioned by Dr. Padmanabh Shenoy, is also recommended for malignancy patients as well, but it is almost never used in our clinics because anyway all these patients are candidates for zoledronic acid. But of course, patients who are not candidates for aromatase inhibitors also may get assessed with the FRAX score, which is quite a useful clinical tool. Now, adjuvant bisphosphonates, as I said, is considered standard of care for all postmenopausal breast cancer patients who are on aromatase inhibitor therapy, and it should be given for at least 3 years. Denosumab is an alternative option for women who do not tolerate zoledronic acid or who are unresponsive to oral or IV bisphosphonates. Now, there is no consensus on the optimal strategy for monitoring these patients, but typically we measure the BMD is measured once in a year or sometimes once in 2 years. But zoledronic acid is to be given for at least a period of 3 years as long as they tolerate. Thank you.
All right. Thank you, Dr. Arun Philip, for a very interesting talk. We have 2 comments from Dr. Sanjay Brada, sir, and we wrote just that each and every component of bone is affected by steroids. Rheumatologists use a lot, oncologists use a lot, and steroids basically are cyanide for the bones. So we have to be very careful about that, when you're treating one disorder, you should not be creating some other disorders. You have to be very careful regarding that. So some questions for you. If I can start sharing my slide, you can unshare. I'll be sharing my slides.
1 minute. Yeah, I have unshared. All
right. Thank you very much. So some questions that we have for you are, for example, we already heard about the steroids and the steroid-induced osteoporosis, right. The journal or the specific measures that you can initiate to decrease the risk of osteoporosis. So do they differ for patients who are planned for GnRH agonist therapy or aromatase inhibitor therapy? Because you're inducing a state of hypogonadism in this case, whereas right. Steroids have effects all over. They decrease calcium, vitamin D absorption from the gut. They increase the calcium excretion from the kidneys. They decrease 1-alpha hydroxylation, but they are not there with GnRH agonist or AI therapy. So what journal-specific measure would you advise to your patients planned for GnRH or aromatase inhibitor therapy? Yeah, for aromatase inhibitors therapy, we have our own guidelines from the European Society of Medical Oncology and the National Cancer Collaboration Network from the United States, from the states. So all these guidelines routinely recommend the use of vitamin D and calcium supplementation. Now, vitamin D plus calcium supplementation is recommended for all patients who are initiated on aromatase inhibitors. Along with, once the day you start aromatase inhibitors, they started on vitamin D and calcium. So that is a consensus recommendation, and that is generally done for almost all patients who started on aromatase inhibitors. And of course, exercise is also one part that is we frequently stress upon for patients who start on adjuvant therapy in breast cancer or in any malignancy for that matter, because
1 hour. Now, the present recommendation is a 1 hour of physical activity, brisk walk, amounting to brisk walk for at least 6 days in a week. Now, that is supposed to, be immunogenic. That means it improves it is supposed to improve immunity and, prevent recurrence of breast cancer. That this particular, physical activity probably helps in bone health as well. So, as a general measure, all our patients are given advice for a brisk walk for all patients who are able to. I mean, a brisk walk of at least 1 hour a day for at least 6 days a week. And of course, calcium and vitamin D, as I already said, are the other measures that we advise.
So you were talking about T-scores, whereas what you're inducing is secondary osteoporosis. So you should be more concerned about the Z-score. So what exactly would be the difference between T and Z-score, and or what is the definition osteoporosis with the Z-score?
Yeah, so I'm not an authority on this the Z-score and the T-score as far as DEXA is concerned. Most of our endocrinology friends, help us out with. Prem was already there at Amrita when till a few months back. So these guys used to help us with the DEXA scan reports. But what I understand is Z-score is usually it's set for patients who are younger than 50 years, and T-score is more common in use for patients who are above 50. So when a patient is has a C-score which is low, even if the T-score is normal, one indication in a premenopausal patient is probably could be due to a secondary cause. So that's my general understanding, but I think some of the panel members probably could help us out in this regard. We usually do not, most of our patients, breast cancer postmenopausal, are above the age of 50. So most of the time we look at the T-score and, okay, patient is osteopenic or the patient is osteoporotic. Either way, irrespective of the T-score, they have to be started on bisphosphonates because it improves survival as far as breast cancer is concerned. So no patient escapes bisphosphonates when on aromatase inhibitor therapy. So that's like, two birds with a single stone. So this question, I think I'll have to pass for, with regards to secondary osteoporosis and Z-score. Not really sure about, the significance. Prem probably.
Yeah, you passed that question to Prem, so we'll take that to Prem later on. But the T-score is race and gender matched, and you bring in age matching with the Z-score. So secondary osteoporosis, Z-score is more important. -3 and lesser would be osteoporosis, secondary osteoporosis, whereas -2.5 and less is for the T-score.
Is that for patients or just premenopausal or less than 50-year patients?
There is no age matching in the T-score. There is age matching in the Z-score.
So
Prem will probably have something on
yes, I do have the slide.
also.
Yeah, I do have the slide. Yeah.
One of the slides. All right. So you were talking about the dose of zoledronate acid, 6-monthly dose in multiple myeloma. You talked about ibandronate also. Why not alendronate? Because I think for osteoporosis, it is more effective than ibandronate.
That's true. For patients on multiple myeloma, the data is very, very scarce with regards to all oral, bisphosphonates. Maximum data is for zoledronic acid. It's the same with all malignancies. Hypercalcemia of malignancy, any malignancy with bone metastasis, or breast cancer patients on adjuvant aromatase inhibitors. If you look at the literature, zoledronic acid has, the maximum data, and ibandronate and alendronate very little literature. But there are many clinics in the West where they routinely use oral aromatase inhibitors like either alendronate or ibandronate. So alendronate, we've never used in the clinics, but many of our patients who do not want IV therapy are on ibandronate, but never alendronate or the other oral bisphosphonates. Of course, but we've had patients who are referred from the West who've been given, once weekly dose of alendronate, but in our clinics, almost never.
That would be a 70 milligram dose of alendronate again, weekly dose. And all right, so there are some data for alendronate also. So it's probably somewhat better because we prefer ibandronate. We don't prefer ibandronate. We prefer alendronate over ibandronate because it's more effective. So zoledronic acid, you use a higher dose than us. Have you seen any complications like ONJ and all in your patients?
Yeah, absolutely. So zoledronic acid, most of the complications that we face is acute infusion reactions. So many of these patients go on to develop, fever and severe myalgia, and some of them discontinue after the first dose. They're not willing to continue zoledronic acid after the first because of the infusion reaction. Renal failure is another issue we have encountered, and few of our patients have even had to go on dialysis after renal failure due to zoledronic acid. So that's a major concern. ONJ, many patients who've been on long-term zoledronic acid have developed ONJ. ONJ is a very, very messy thing to treat. So we have a very huge head and neck oncology department, and it's a nightmare for them, to treat ONJ once it sets in. They develop repeated infections, osteomyelitis, and it's very hard to treat. So zoledronic acid is not very, very friendly, but the sad thing is most of our data is on zoledronic acid. Now, of course, denosumab is coming up, but many of our patients may not afford denosumab.
Probably the last question for you. For oncology, CA breast, CA prostate, it's basically, CA breast would have mixed osteoblastic, osteolytic metastasis, whereas there are mostly lytic, lesions for CA prostate. So does that change your therapeutic plan for osteoporosis in these patients who have got metastasis to the bone?
Metastasis, yeah. So it's a good question in the sense that the metastasis in prostate is very, very different from that of the breast. So breast, you usually see mixed lesions, predominantly lytic lesions in breast, and prostate is mainly osteoblastic lesions. It is more of sclerotic lesions in prostate. So in prostate cancer, when the patient presents with metastasis, they need not be given bisphosphonate therapy to cover for the metastasis. In the standard of care in prostate cancer is to reduce the testosterone levels. So to bring down the testosterone level to zero, that improves the bone health as well. So if you look at the data, prostate cancer patients with bone metastasis do not need upfront bisphosphonates. They are only given bisphosphonates once they become castrate resistant. So till they achieve that castrate resistant stage, bisphosphonates are, they do not have any added benefit over androgen deprivation therapy. So you deplete the androgens, that itself improves the bone health to the fact that the fracture is prevented. So in breast cancer, on the other hand, all patients who have metastatic breast cancer are given monthly zoledronic acid for a period of used to be, but now we have data coming up which shows that 3 monthly zoledronic acid is as effective. And so standard of care is staged 3 monthly zoledronic acid given for a period of at least 2 years. So zoledronic acid rarely used in prostate cancer if you look at the data, but in the periphery where a lot of prostate cancer patients are treated, zoledronic acid is started right at the beginning of therapy. But there are enough and more studies which have shown that zoledronic acid adds nothing to preventing bone fractures or preventing improving the prognosis of the cancer per se with zoledronic acid. So only start zoledronic acid once they become castrate resistant. So that is a very important difference. Probably good that you brought up this question.
So it is basically that in prostate cancers, whenever you give a GnRH agonist and you induce a hypogonadal state, probably that time when you are going to maintain that hypogonadal state for a very long time, you will need osteoporotic therapies at that time.
Yeah, some of these patients who have BMD less than T-score of less than 2.5 are initiated on 6 monthly zoledronic acid solely for that purpose, not for the metastatic disease, but for osteoporosis. Correct.
So for CA breast, probably you can start very early, but for CA prostate, probably after you maintain a hypogonadal state, that would be the time that you'll start the therapy for osteoporosis. Thank you, Dr. Arun, for a very interesting presentation and a very interesting question and answer. I invite Dr. Prem for his presentation, and then probably we'll take up the discussion with the panelists and the speakers after that. Dr. Prem.
Thank you.
Good evening, one and all, and thank you, Dr. Saket, for the kind introduction. And so my talk for the day will be postmenopausal osteoporosis update. Yes, so this is a picture. Yes, I still remember the MBBS days. First, I've seen from the textbook of gynecology that is shows, which my madam, Bina madam, had taught during the MBBS days, and the Dowager's hump, the name still I remember. So this is a very, very important picture, and so this is what my talk will be based on. Just a case, and then the definition, pathophysiology, screening, diagnosis, and treatment. So that will be my agenda for the day. So a 60-year-old female with no significant past illness with menopause since 2005. In 2016, she had a Colles right fracture, and June 2016, backache, detent compression fracture was evaluated for the secondary osteoporosis, and the calcium, phosphorus, PTH, and all was normal, and with vitamin D was on the insufficiency range. And you can see here the T-score at the AP spine was minus 4.5. So which is suggestive already with the fracture, compression fracture. So she's having a severe osteoporosis, and you can see the Z score is minus 2.9. So below minus 2, it is very significant. So this is a background for the postmenopausal osteoporosis. So to define osteoporosis, as you know, it is a progressive systemic skeletal disease with low bone mass and microarchitectural deterioration of the bone tissues, resulting in bone fragility and susceptibility to fractures. Epidemiology, in the start itself, we had seen 1 in 3 women more than 50 years, 1 in 5 men more than 50 years can suffer the osteoporosis and the fractures. 50 million people in India are either osteoporotic or have low bone mass. Even the data would be a very underestimated report, because even much more than will be there in the range. So some of the facts is the lifetime risk of dying from the hip fracture is as same as that from the breast cancer. And the osteoporotic fracture in men is more than the combined myocardial infarction and the prostate cancer. So that shows the importance of looking into the bone density in both the population, that is men and women. 1/6 of postmenopausal women can have fragility fracture at any skeletal site. You can see here how burden of the osteoporosis. So this is some of the, you can put up like the osteoporotic carrier of a female. You can see here around the age of just before the 55 to 60 can start with the wrist fracture we have seen in our patient, and it can slowly progress to fragility fractures at the wrist, humerus, ankle, or vertebrae, whichever sides. Even so, we have seen that our lady even had a compression fracture, the vertebrae also. And so ending up, which will the ultimate will be the hip fracture. And you can see here the excess morbidity associated with the fracture event progressively increases as the age of the lady or the age of the female increases. And we know that presently the longevity has increased. So as if we are not identifying the osteoporosis, the morbidity due to the osteoporotic fractures will also increase. Then the etiology, yes, primary and secondary, broadly classified. Primary, as you will know, the age-related sex hormone deficiency, yes, commonly the postmenopausal women. And secondary, yes, we have a whole lot of things in the secondary osteoporosis. We had 2 important discussions on the steroids. There is a drug-induced category, and also even the drug plus the secondary malignancy induced risk from the Dr. Arun. And endocrine point of view, you can see here various other causes. Yes, hypergonadism, and most importantly, hyperparathyroidism. Always wrote out in the workup the hyperparathyroidism, because that is very much underestimated. Even hyperpara, there are a lot of patients in the community with hyperpara and osteoporosis. And again, diabetes mellitus very important, and hypercortisolism, and also even acromegaly, and then other less important, less seen causes, hypophosphatemia and porphyrias. So the pathophysiology of postmenopausal osteoporosis, you can see here, we know that broadly we have the cortical bone and we have the trabecular bone. And trabecular bone is the most active, metabolically active bone. And the 3 important cells are the osteocyte, osteoblast, and osteoclast. And the 3 important hormones are the sex steroids, parathormone, and vitamin D. These are the 3 important hormones that act on the bone cells. So we know, yes, the multicellular bone units, on the one side, the bone formation can happen, the osteoblast, and the osteoblast express the rank L, and also inducing the osteoclast activation, and osteoclast they form the cup-shaped units, the cathepsin enzymes and all will resolve the bone. In postmenopausal osteoporosis, bone resorption is increased by around 90%, but the formation is increased by around 45% only. So there is a there's a gap between the formation and the resorption. Resorption is more. So the two phases of bone loss, the short phase initially from the trabecular bone, annual loss at the rate of 3 to 5%, and occurs in the short phase of initially and after the postmenopausal phase, that is initial 3 to 5 years. Then the second phase of rapid phase, that is in the 10 to 20 years later, the cortical and trabecular bone loss adds to it. Estrogen deficiency, how it affects osteoporosis is it alters the signaling of the estrogen, impaired osteoblastic, osteoclastic, and osteocyte activation. So also the impaired macrosensing by the osteocytes, and also an upregulation of the whole, lot of array of pro-inflammatory cytokines. Next, we move on to the screening and diagnosis. So baseline lab test in any osteoporotic workup should be, there should be a creatinine, there should be a fasting sample of calcium or phosphorus, and if you have the facility, you can straight away go for the ionized calcium, and alkaline phosphatase should be there, then intact PTH, and also 25 hydroxy vitamin D levels. Then for the further workup, if you're suspecting, you can go for a 24-hour urine calcium phosphorus. Then for the secondary other workup, for the anemia, multiple myeloma and other malignancy workup, CBC and LFTs, protein electrophoresis, and even for the nutritional part, then the TTG will be helpful. So this is not the routine, but the first set would be the routine test that must be done, because or else you will miss many of the common conditions. Diagnosis, yes, gold standard is bone mineral density measurement at the hip and also the lumbar spine. And the device is a dual X-ray energy absorptiometry designated as DXA. DEXA, it is not DEXA like the dexamethasone. It is DXA, and we usually measure the T-scores in the postmenopausal females. When the T-score is -1 or above, that is less minus, it will be normal. When it is between -1 to -2.5, it is low bone mass or osteopenia, and -2.5 or below is osteoporosis. Then the T-score is defined as a standard deviation of an individual's bone mineral density from the mean value for healthy young women. So we are comparing the bone density with the healthy young women. How many standard deviation the female has gone down? Well, the Z-score is defined as a standard deviation again of an individual's BMD from the mean value for the age-matched reference population. That is important. So we compare it with the particular age-matched reference population. So the ACE diagnosis of osteoporosis in postmenopausal women, as already put up, -2.5 or below in the lumbar spine, femoral neck, or the distal radius. Low trauma, spine or hip fracture, definitely you should suspect, or regardless of BMD, definitely you should suspect osteoporosis. Osteopenia, as already put up, with a fragility fracture. Fragility means a low trauma fracture, like the patients walking and on the road and slipping on, tripping and down and then having fracture, or falling down in the bathroom and then having a fracture. So this can be considered as a fragility fracture. Then again, osteopenia with a high FRAX score for the country-specific threshold, you should consider osteoporosis. So FRAX will be coming up. Why an T-score of -2.5 has been kept up? So this is, an interesting part. In adult women, the cutoff value of 2.5 SD below the average of the healthy adult reference range is appropriate to satisfy most of the criteria, particularly for the hip fracture. And this cutoff value, that is -2.5, identifies approximately 30% of postmenopausal women as having osteoporosis using measurements made at the spine, hip, or forearm. And hence, this is approximately equivalent to the lifetime risk of fracture at these sites. And that is why the 2.5 standard deviation below has been taken as a cutoff, because it will cover the 30% of the postmenopausal women, and which is having the lifetime risk of fracture at these sites. This is from the Canis paper at 1994, and it still holds very good. DEXA machines, very important. 4 machines are the one I missed it. The Hologic, the Luna Prodigy, the Nolens, and also the Medilink. And the Luna Prodigy GE is a commonly used one. The other ones are also available. During the discussion, we might we can see the differences. This is the usual GE Luna Prodigy machine. And you can see here, the patient is lied down. You can see The palms are placed by the side with a slightly gap. And you can see the at the foot end, it is closed and it is tied down, or it is kept in place. And the head should be up with the chin in the neutral position. So this is a positioning a patient on the DEXA machine. What are the indications for BMD testing? When should we test it? All women postmenopausal above 65 years old, it is always prudent to have a BMD checked. And also all postmenopausal women, irrespective of age, those with a pathological fracture, or if you're suspecting osteopenia or low bone mass in the X-rays, routine radiography, or those on steroids therapy more than or equal to 3 months. Also, you can consider in this category also those with early menopause with less than 40 years menopause, those with a BMI less than 20, those who are current smokers, and also those who are using excessive alcohols. And this is some of the picture of the bone density measurements you can see here, and the representation grams per meter square. So that is a aerial BMD is what we are measuring. Then the frax. Frax is a very, very important. You would have heard it in the previous two speakers talking about frax. It predicts the 10-year probability of major hip fracture and major osteoporotic fracture. And country-specific probabilities should be there based on the epidemiological data. It is available as an online tool, and frax with or without BMD can be calculated. And country-specific threshold should be there. If some country is not represented, it will not be useful to use the frax scoring for them, because it will change. Because I've seen, I had Maldivian patients coming, but we do not have data for those category in the frax. So we'll not be able to calculate the frax in them. So you can see here, 12 points are given in the questionnaire, and you'll have to fill it up online. And India has the data definitely. And the points are like age, the gender, weight, height, previous fracture, parent fracture, current smoking, steroids, rheumatoid arthritis, other secondary osteoporosis, if any, like this hyperpara, anything you came across, alcohol intake more than or equal to 3 units per day, and the femoral neck BMD you can choose, or even the if the machine specific, you can put hologic, or you can put the lunar, again machine dependent also you can put it up. And frax is not validated in these circumstances. It is not valid for use with a total hip or lumbar spine BMD. It is a femoral neck that we put up. For ethnic minorities, as already I put up, we do not have the data. For those receiving osteoporotic treatment, it is not validated. And for ages outside the specified range of 40 to 90 years also, it is not validated. Then next we move on to the bone turnover markers. Many of you would have heard in the clinical practice recently, more heard it is bone turnover markers. The bone markers can be, as put up, there can be catabolic markers and anabolic markers. The catabolic markers, you can see here CTX or NTX, the C-terminal or the N-terminal telopeptides, the matrix-derived bone markers that we commonly use, or even the cell-derived marker will be the TRAP, that is the acid phosphatase. And the anabolic markers would be the P1NP, or the type 1 procollagen peptide, or osteocalcin, or the bone-specific alkaline phosphatase. So the top part is the catabolic, and down is the anabolic markers. What is the use of bone turnover markers? Can it be used to diagnose a bone turnover, osteoporosis? No, it cannot. Can it predict? It can predict the rapid rate of the bone loss only. And usually what we use is a CTX or the P1NP as a reference analyzer. It may be useful for fracture risk assessment. Yes. Determining the medication compliance, very important. It definitely can. Drug absorption, yes. Those who are on oral therapies like the oral bisphosphonates, drug absorption, definitely, or compliance. And also you can use it for therapeutic efficacy. Because BMD, if you want to assess, it will take at least 1 to 2 years to assess a response to therapy. But BTM, you can use it, yes, even as early as 3 months to assess a response. So that is a convenience and added to the assessment of the therapy response. Next, fracture risk classification. So you can see here 2FNT. So the first F stands for the fracture, and the second FX I have put up is a frax, and the T stands for the T-score. If all three are negative, no fracture from the history, no osteoporotic fracture. And the frax is also not crossing the limit. Usually the hip fracture, major hip fracture is more than 3%, or the most major osteoporotic fracture more than 20% is cutoff. If it is down the cutoff, it is negative into, and T-score, it is not crossing the lower value of -2.5, then it is in the low risk group. Then the second comes, the T-score is less than -2.5, but a frax is not crossing the limits and no fracture history. Then that comes in the moderate risk classification. And when there is already a fracture, as in our patient case, we have seen some osteoporotic like the disc fracture or the compression fracture, and even the frax is crossing the limit of hip or the major osteoporotic fracture, and the T-score also crossing down, then the patient falls into the high risk category. And very high risk are those patients with the multiple spine fractures, and the BMD T-score at the hip or spine is -2.5 or below. They go into the category of very high risk. So this is a low, moderate, high, and very high risk simple categorization. Then how can the bone loss and fracture be prevented? There are non-pharmacological and pharmacological methods. What are the goals of our therapy? We need to maintain the skeletal mass. We need to preserve the integrity of the skeleton. We need to prevent the falls and the fractures, and hence the morbidity and also the mortality. Non-pharmacological measures are restrict the caffeine intake to less than 240 to 360 ml per day of caffeinated drinks, less than 1 to 2 servings. Good protein intake, 0.8 to 1 gram per kilogram, helps minimize the bone loss. Alcohol, not more than 3 drinks per day. And smoking definitely should be stopped, especially in postmenopausal female, because it increases the osteoporotic fracture risk. Then the vitamin D recommendation. The Endocrine Society has given that the 25-hydroxy vitamin D more than 30 as sufficient, or it is normal. But other two guidelines have suggested more than 20. So we are yet to have an Indian guideline cutoff on that. Still, we follow the Endo Society guideline as 30 as a limit. So most probably all the osteoporotic patients with fractures will be having the vitamin D deficiency also. So we replenish with a D3. Maybe you can give the oral one, 60,000 units, around 6 to 8 weeks, or even if you find further at lower side, you can give it up to weekly for 8 to 12 weeks also. Maintenance therapy of 1,000 to 2,000 units daily. Or you can give, injectable also. If the patient is having other comorbid illness, etc., absorption may be not great. You can give 3 lakh units as a single shot, which can last up to 3 months. And then you can give oral. Calcium intake, very important. Elderly, those above 50 years, male or female, at least 1,000 to 1,200 milligram of elemental calcium should be taken. Then the calcium preparation, you will be flooded with a lot of calcium preparation in the market, 500, 1,000 and all. Most of the time you can get confused. Calcium carbonate is the common preparation, and 1 gram of calcium carbonate will contain only 400 milligram of elemental calcium. And then the calcium citrate malate is available in the brand names like CCMs and etc. 1 gram of calcium citrate malate will contain only 211 grams of calcium elemental form. Calcium chloride, not much commonly used. 1 gram will contain 273 milligrams of elemental calcium. Calcium acetate is sometimes used in the renal category patients. 1 gram will contain 253 milligrams of elemental calcium. And IV calcium gluconate, you can see 1 gram will contain 93 milligrams. You can be given calcium gluconate. Then, what is the role of calcium vitamin D in the fracture risk reduction? You can see a non-vertebral fracture, calcium, vitamin D, and both combined. You can see some good data on the reduction is there. But in the hip and vertebral fracture, it is meager. And the hip fracture, you can see calcium and vitamin D combined. There is some reduction. You can see around 20% risk reduction has been shown. So this is one of the community dwelling older adults from paper from JAMA. The use of supplements compared calcium or vitamin D compared with placebo no treatment was not associated with the lower risk of fracture among the community dwelling adults. So those findings do not support the routine use of these supplements in community dwelling older people. But in those with osteoporosis, definitely it is justified use. Then regular weight bearing exercise, yes, walking or even the weight training exercise can also be given. Prevention of falls is also very important. Then who needs pharmacologic therapy? Osteopenic with fragility fracture of the hip or spine, definitely. T-score minus 2.5 or below at any of the sites, definitely. Osteopenia with a high fracture possibility, more than 20 osteoporotic fracture, hip fracture more than 3% for the country-specific threshold. Yes, definite indication for treatment. So when you come to treatment, what are the treatment available? There are two groups, anti-resorptives and anabolics. Anti-resorptives are the bisphosphonates, everybody know. Denosumab, raloxifene, the SERM, selective estrogen receptor modulator. Strontium, not used. Calcitonin, andronacative. And the anabolic, we have the teriparatide, abloparatide, and the romosozumab. Only teriparatide is available in India. We will see the anti-resorptives, bisphosphonates, yes, the derivatives of the inorganic phosphate, inhibit the farnesyl pyrophosphate synthase activity in the metabolic pathway. Majorly, what happens is that it inhibits the osteoclast, and so osteoclast apoptosis will happen. So these are the various like the bisphosphonates are available, and the most important is the zoledronic acid. You can see the relative potency is 10,000 compared to the etitronate with the relative potency of 1. So very highly potent is zoledronic acid. It remains in the bone for long time, maybe even 10 years or beyond. Yes, it is renally excreted, and all our nitrogen-containing bisphosphonates are, except ibandronate, are the first-line options in the postmenopausal osteoporosis that's put up as PMO. BTM, reliable surrogate marker of efficacy and potency, and maximum suppression of resorption within the 3 months of oral therapy. You can see the doses and all. Yes, zoledronic we give. Yes, usually the osteoporosis we give the 4 mg dosage also, and the creatinine clearance should be more than 35 ml per minute. For alendronate also, the creatinine clearance should be more than 35 ml per minute. Fracture risk reduction with all the bisphosphonates has been shown. The green is a vertebra. Yes, the pink is a hip, and the purple would be the non-vertebral fractures. All shows definitely good. Except ibandronate, no effect on the hip, except in those with very low BMDs, -3 or below. And zoledronic acid, you can see here, yes, very good data on the reduction of vertebra, hip, and also the non-vertebral fracture. Adverse effects, oral ones, yes, the GI intolerances. IV ones, you all know, yes, as already put up, fever, myalgia, and even rarely AF. And ONJ and atypical femoral fractures are also the very, broader complications that could, if happening, can happen with the those on therapy. Risk factors for atypical femoral fractures would be inadequate response to PTS to hypocalcemia, obesity, early menopause, and younger age. These people can have an increased risk for AFF. The warning symptom: a patient on bisphosphonate complaining of a thigh or a groin pain, definitely think of a risk of atypical femoral fracture. And you can see here the fracture that has happened in the shaft. And the duration of therapy, yes, moderate, low risk, oral up to 3 to 5 years, and parenteral for 3 years, definitely. And after that, you should consider drug holidays. And higher risk category, oral up to 10 years and a parenteral up to 6 years. We have data, and then rest we'll have to look into the clinical condition of the patient and decide on. Denosumab, yes, the rankle inhibitor of the osteoblast, and it is a monoclonal antibody. And the freedom trial showed reduced reduction in the vertebral fracture of 68%, also good reduction in the hip and also the non-vertebral fracture, given as 60 mg subcutaneously every 6 months. So 6 monthly dosage. Prefilled syringe, yes, again the ONJ and AFF risk can happen. No dose adjustment with hepatic or renal impairment. And hypocalcemia, if severely impaired, renal impaired patient, you should definitely be careful because of the risk of a hypocalcemia. Those who are stage 5 or dialysis, it is usually not recommended. And drug holiday, usually not given as in the zoledronic acid or bisphosphonate. What happens if you treat, if you are given denosumab for quite some time and stop it? The bone turnover markers will increase and the bone mineral density will come after 2 years. So it will decline. The effect, whatever you have gained, will decline. No published data beyond 10 years. Up to 10 years of treatment, we have good data, but beyond 10, we have to wait for more data. Then the SERM, raloxifene, weaker anti-resorptive, 60 mg tablets daily. The MORE trial showed the vertebral fracture risk reduction, but again, the RUTH trial showed that there is small increase in the risk of fatal stroke with the raloxifene, mild, but it was significant. Basedoxifene, yes, again, vertebral fracture reduction is shown with 20 mg monotherapy, and also it can decrease the endometrial hyperplasia, so that is an advantage. And then the newer kid in the block, CERM, that is lasofoxifene. Pearl trial showed good data of vertebral and non-vertebral reduction fractures, and even reduction in the breast, CA, CHD, and stroke, and approved in Europe, but pending in US. HRT, yes, very good option, but when the WHO trial came up with the increased risk of vascular events and breast cancer, people have come down with the usage. But if you prudently choose a patient less than 60 years and less than 10 years from the menopause, definitely it is also a good option, because we have the newer preparations of 17 beta estradiol preparations, unlike the older conjugated equine estrogens, and also the unlike the synthetic, we have the natural type of progesterones also available. Calcitonin, yes, some data is there. Proof trial, vertebral fracture reduction, no reduction in the non-vertebral fracture. Cathepsin K, oronacatab, and balicatab, oronacatab withdrawn due to stroke risk, balicatab withdrawn due to skin reaction. Saracatinib, or the SRC kinase inhibitor, in phase 2 trial only, not going to detail. Strontium, it's not available. We are not using. Had some antiresorptive anabolic activity. I have seen one patient in Amrita. She was from US and she was on strontium. There it is available. We don't have it. Next, we move on to the anabolic agents. Yes, the teriparatide, PTH 1 to 34, 20 microgram daily subcutaneous is and the thiopurine is a dosage. Very good reduction in the vertebral fracture. You can see here more than 65% compared to the placebo. And total duration of therapy is restricted to 2 years, because in rats it showed the osteosarcoma of the hip. Hence, it is not presently approved beyond 2 years of dosage. But there are some interim analyses which have shown that in humans it does not demonstrate a causal association. But you should avoid teriparatide in patients with Pegas disease of the bone, unexplained ALP elevation, avoided prior skeletal radiotherapy, primary metastatic bone malignancy, and primary hyperparathyroidism, definitely. Abaloparatide, again not available in India. Again, it is a PTH receptor agonist, FDA approved in 2017. It acts on the special conformation of the PTH receptor, and 80 micrograms daily is a subcutaneous dose. Maximum again sealed at 2 years. So this is abaloparatide data with the active study, and it has shown 86% reduction in the new vertebral fracture, even much better than the data shown from the teriparatide, and even some reduction in the non-vertebral fracture also. And incidence of hypercalcemia was lower with abaloparatide compared to the teriparatide. Romosozumab is latest kid in the block, the sclerostin inhibitor. We have seen the WNT-catenin and its effect on the osteoclast. And the frame trial was the one that showed, approved in 2019. Initially had some cardiovascular risks and all, hence it was not approved, but later it was approved. And 73% lower risk of new vertebral fracture at 12 months compared to the placebo. And it also increased the BMD at the lumbar spine, femoral neck, and also the hip also. And you can see here the new vertebral. So you can see the data, the vertebral fracture reduction 73%. And also if the patient was on romosozumab and after 1 year, patient put on dindosumab, again still you can see a 75% in the fracture risk reduction. And to an extent, some data on non-vertebral fracture is also available. Pipeline drugs, osteobolin C, yes, a cyclized parathormone analog. Calcilytics, yes, which can block the calcium sensing receptor in the parathyroid gland, and where is increasing the PTH. And also GLP-2 analogs, some of the kids in the block. And this is just to summarize, which I've already discussed with you. Monitoring, how to monitor, yes, BMD is a prudent one. 1 to 2 years, you can use it. Stable or increasing BMD appears to indicate a good response, and the least significant approach we can use. Failure of treatment, this is very, very important. Loss of BMD more than the least significant change over 2 years, like already put up, the least significant change. Then the BTM decrease on anti-resorptive drugs less than the least significant change. So we are expecting an LSC. The BTM decrease on therapy is less to that. Then again, you can consider failure. 2 or more fractures while on therapy. Noted 2 or more, especially vertebral, definitely is a failure. 1 new fracture and a decrease in the bone mineral density more than the least significant change is significant fracture. And one new fracture and decrease in the bone turnover marker less than least significant change is also important. Might be confusing. We can definitely have a discussion on that. And one fracture during active treatment does not mean failure of treatment. So if the patient is on therapy and just a fracture occurred, this does not mean that the treatment is a failure. So that is a take home point on that. And there are now with a lot of drugs available, can start with either resortes followed by anabolics, or whether it is anabolics followed by resortes is good. Yes, resortes after anabolic agent, you can consider after the 2 years of therapeutic therapy, oral alendronate or IV zoledronate is a good option. Raloxifene to some extent also a good option if the bisphosphonates are not tolerated, and also denosumab is also a very good option. Then anabolic after anti-resorptives. So that means the patient is given anti-resorptive drugs and you're then trying for anabolics. But the effect is not that as good if you're following the anti-resorptive by anabolic, because it will blunt the BMD response and accelerate. If you are giving denosumab to, if the patient was on teriparatide and you're then giving the denosumab, it can accelerate the bone remodeling because the denosumab acts like that. Hence, the following up of denosumab by teriparatide. First, if you're giving denosumab, then giving teriparatide is not a good option. That will accelerate and result in bone loss. Then now it is a combined therapies also there. The data study also you can see here. Teriparatide when combined with denosumab has shown a good gain in BMD. We have the BMD response is good, but we do not have the fracture data on that. So this is just the algorithm. You can see here low to moderate risk and high to very high risk from the Endo Society guidelines. And you can, if the low risk, you can reassess a fracture risk, and moderate risk also. If the other parameters are fine, you can wait. High to very high risk, you can have the options of bisphosphonates, denosumab, and teriparatide only in India, along with the calcium and vitamin D. And then you can follow the algorithm accordingly. So what are the dilemmas and gaps that we have? Are we treating according to the physiological needs of the skeleton? Increased life expectancy. Because of the increased life expectancy, we need more than one agent through the lifetime. And the risk associated with the prolonged usage of the anti-resorptives, they stay in the bone for the much longer time. Teriparatide, we are able to use it only for 2 years. Romosozumab, so far data only for 1 year treatment. And treatment failures are also an important gap. So the take-home points is moderate to high, low to moderate, you can follow it up. And moderate to high risk, yes, you could consider sequential anti-resorptives. Like the patient is aged between early 50s, yes, HRT is a good option. The patient is between 55 to 65, moderate to high risk, also you can consider the raloxifene. And if the patient is 65 or above, you can definitely go in for the bisphosphonate or denosumab. Even that can be considered earlier also, if necessary, in the patient is on high risk and we are expecting more risk of fractures. Very high risk patients, always better to go for an early anabolic agents. So thank you all for the patient listening.
Thank you very much, Dr. Prem, for a comprehensive talk on osteoporosis management and follow-up. We'll probably be taking up the questions that we have from the audience, and so I'll be, you must be tired after that talk. So I'll start with probably Dr. Vivek right now. He was talking about volumetric BMD as also aerial BMD. So if you try and make an assessment of the quality of bone and the quantity both, probably volumetric BMD would be much better than an aerial BMD. So why do we not use it more commonly?
So as Dr. Prem has already mentioned, that volumetric BMD has some advantages over the aerial BMD, and it gives us a better idea of the bone fragility, fracture risk as compared to the aerial BMD. But the three major issues with volumetric BMD are first is the availability of the volumetric BMD, which it is not very easily available at all the sites. Probably in Delhi or other metros, you can find it easily, but not everywhere it is easily available. The second is the cost. Cost of the therapy is also, cost of the investigation is also high. The radiation exposure is also quite significantly high as compared to the aerial BMD. And when we are using osteoporosis like chronic disorder, and we have to monitor regularly with this investigation. Again, the radiation exposure needs to be taken into account. And last but not the least, the population data of the aerial BMD, which is available with the DEXA scan, is very huge, not only for the diagnosis, but also for the follow-up and monitoring of the therapy. It is very huge as compared to the volumetric BMD. And because of all this reason, despite having some of the advantage over aerial BMD, it is not very commonly used, the volumetric BMD.
All right, Dr. Shenoy is not here. Dr. Prem will have to take up his question. We had a question in the chat box. Best site to look for glucocorticoid-induced osteoporosis. If you have to choose one site, which one would that be?
Definitely, I would say the steroids and the metabolically active site is vertebra. So I will go for the vertebra because it is, I mean, the endocrinologically the most metabolically active bones is the trabecular bone, and so it says to vertebra would be the site.
All right. So you have Dr. Vivek. You must have a lot of people coming to you with heel portable BMDs, and they give erratic results. You get it done once and you get it done the next time. Probably a small calcinian spur also would change the data. So how do you find it? The heel portable BMD, small machine, carry it anywhere, just do it anywhere. For if you can have a screening of a large population in a short time. So how do you find it? It's basically a useless device, or it is somewhat useful for your practice?
I would say it is not completely useless, though the diagnosis or the monitoring of the therapy or the treatment initiation would not be very much based on the heel portable BMD. However, as you already mentioned, that with the convenience portable device, screening of large population, they are the some of the plus point. Also, as Dr. Prem has already mentioned in his slides, that with heel portable BMD, though we cannot diagnose osteoporosis, but we can estimate the fracture risk. And in some of the patients, when the DEXA or the QCT is not possible, even if we start treatment on the basis of fracture risk, in sometimes when the BMD is not even required to consider for the treatment. So in that scenario, even with the heel portable BMD, we can estimate the fracture risk and we can go ahead for the treatment. At least we can convince our patient to go ahead for the DEXA scan, because sometimes it is difficult because patient is completely asymptomatic and we are sending patient for the DEXA scan. So we can give some idea that, see, you have this much of high fracture risk, you should go ahead for the DEXA scan. So it is not completely useless. There are some of the benefits of this machine also.
So it is very intrinsic comment. So it is basically has a very high negative predictive value. If it is normal, you don't need to go ahead. But if it shows something, then probably you can convince the patient to go in for a proper BMD. I have a question for Dr. Prem from Dr. Amit. And how do you measure exactly volumetric BMD?
Yes, sir. Volumetric, as you know, so the 3 dimensions will be there. That will be gram per centimeter cube. Unlike the aerial BMD, it is gram per centimeter square. And what we use is a quantitative computed tomography, or the QCT is the one that we use. And the differences which has already discussed by Dr. Vivek. And QCT is the one that we use for assessing the volumetric BMD.
All right. Yes, I guess Dr. Prem would be very happy to take this question. Lunar, Hologic, Norlands, and Medilink.
Exactly.
Differences, you already discussed up the differences between these. So if you get it done on one single machine, probably you'll have to follow up on the same machine. So any preference that you have?
Yes,
I guess only one question.
as you have shown, all these 4 machines, the best I mean, when I came with the search, the best was with the Medilink. The Medilink, it has 256 detectors. So the resolution of the images are the highest with the Medilink. But I don't know whether it is available anywhere in India or anywhere. Commonly that we use is a Lunar or the Hologic. And out of the Lunar or Hologic, you can see here Lunar has 64 detectors, and compared to the Hologic, which has 128 detectors. So Hologic would have a better resolution compared to the Lunar. And the cost, I don't know, I mean, the exact cost difference between the Lunar and Hologic, definitely when the detectors are on the highest side or double, the cost will be high, should be higher for the Hologic. Lunar costs around about 20 lakhs, and Hologic definitely should be on the higher side. And again, to put a word on the previous question of heel portable BMD also, as in peripheral centers, if you are not able to put up all these big central DEXA machines, as Dr. Vegas put up, the heel portable BMD, it comes to around 4 to 5 lakhs only. So as a screening, definitely can be put up.
So Hologic is somewhat superior to Lunar.
Yes.
So it is like the new cam that you've got is better than our cams today. All right. So coming to Dr. Veena, so we all know that for osteoporosis prevention, it starts very early, the prevention of osteoporosis, and higher the peak bone mass that you have in early childhood and during the growth phase, lesser would be the bone loss. So how, what is your opinion on the peak bone mass and what role the gynecologist can play in increasing the peak bone mass of our patients?
The peak bone mass is the amount of bone tissue present at the end of the skeletal maturation. And the maximum amount of skeletal maturation occurs by around 18 years, but a little more bone deposition will be till 30 years. And in females, till menopause, there is a very minimal loss of bone, and major bone loss occurs in the postmenopausal age group. So peak bone mass is a very important factor for the osteoporotic risk, fracture risk. So to have maximum amount of peak bone mass is our aim in for reduction of osteoporotic fractures in the postmenopausal age group. And there are different factors that we have in the in determination of the peak bone mass. That is early menarche. I mean, there is more exposure to estrogen. Those people will be having more of peak bone mass. And second is the nutritional factors. That is calcium-rich diet. That's why we always say that you give milk to both male and female children up to 18 years. Because 1 cup of milk contains around 300 milligram of calcium, elemental calcium, along with playing in the sunlight. That is physical activity, very, very important. Physical activity is the regular exercise like weight bearing exercise, walking, jogging, and in schools they can have extracurricular activities like dancing and engaging in the sports. All these things will increase the peak bone mass, and that will contribute significantly to reduce osteoporosis in the future. So also the lifestyle habits like limiting alcohol and avoiding smoking, and sedentary habit that has become a major problem nowadays, because most of the children sit in front of the computer or the mobile phones and they don't play outside playing sun and playing outside the sun, because exposure to vitamin D very vital in the bone deposition during these years. So we have to encourage our children through the school health program activities, and during our consultation also there should be routine risk assessment of osteoporosis risk factors, and you ask the child to be active and having a very having a proper nutrition and with proper exercise. That is very, very important.
So do you think probably childhood obesity, paradoxically, having a negative effect on the metabolism may have a positive impact on the peak bone mass also?
Yes. Because the childhood obesity is mainly due to lack of exercise. And also that is one of the contributing factors, because that is a sedentary habit which is contributing mainly to childhood obesity.
So, all right, thank you very much. And I'll come back to Dr. Prem. You already told us BMD and the least significant change. Now, if on a follow BMD, for example, you have different in the least significant change, for example, in the vertebra and the hip, what would be your, what would you do in that case?
So if available, I would go for a bone turnover marker also. So that can help in the assessing the response, because yes, many of times the bone losses or bone gains at these sites can be different at different sites. So that's where comes the importance of the least significant change. And the least significant change for the particular machine, you have to calculate for the particular institution. So there are the international clinical densitometric guidelines that your technician, there are certain, particular guidelines that you should calculate for your particular machine with the particular technician. And then you can assess, as already I put up during the treatment failure, the least significant change in the BMD response is 5%. So if it is more than that, then it is significant. If it is less than that, then it is not significant. And
that is what exactly what I was going to ask Dr. Vivek. So basically,
right.
bone turnover markers and BMD, they're basically respectively short-term, long-term. So it's something like a short-acting insulin and a basal insulin given together. Why not follow both of them together?
Yes, yes, very much. The both, as Dr. Prem has already said, that the use of bone turnover marker and BMD in combination will give us a lot more idea as compared to the BMD or bone turnover marker alone. The only thing is that whatever the clinical significant change we are going to see, we see very early in the bone turnover marker, maybe within 3 months or maybe 6 months. We see the changes in the bone turnover marker, but to see the adequate effect on the bone mineral density, it may take up to maybe 1 or 2 years before we see the significant change. Therefore, the both in combination, we have to decide that whether patient is adherent to the therapy and whether the treatment is working adequately or not.
So would it basically depend? You've got bone turnover markers, which basically can be, bone formation markers and bone resorption markers also. So would it depend on the type of therapy, whether you're giving an anabolic therapy or you're giving something that's going to inhibit the osteoclast, for example, the dronates, if you're giving, or zoledronic acid? Would you be more, focused on one specific part of the BTM as compared to some other with the specific type of therapy that you're giving, Dr. Vivek?
Yes, very true. If patient is on anti-resorptive therapy like bisphosphonate or the denosumab, we are more concerned with the bone resorption markers and the suppression of this bone resorption marker to the at least significant change. We are more concerned about that. And whenever we are using the anabolic therapy like teriparatide, we are more concerned about the bone formation marker, that is the P1NP, and we see the changes what is happening in the P1NP.
All right, coming to Dr. Sri Ganesh, you already had a fracture. So what exactly would be the indication for surgery in an osteoporotic vertebral fracture? Please unmute yourself. Please unmute yourself. You're muted. You're still muted. You're not audible. You'll have to unmute yourself. You're not audible, Dr. Sri Ganesh. Please unmute yourself.
Unmute only, but I think there is some.
I think there is a problem with the mic.
Maybe you can just log out and log in between. By the time we'll have the next one.
All right. So basically, I'll get back to this question in some time. So we've read all about it. We've seen all the therapies. So which therapy? It basically would depend whether you need an anabolic therapy or an anti-resorptive therapy. But probably PTH for now would be the most effective therapy if used wisely. You have to rule out all other causes. So what, in your perspective, Dr. Prem, most effective therapy, what would that be?
So I mean, to put it, all therapies are effective, but choosing the right patients and on the right therapy would be the most effective thing that you can do. So as I had put up, I mean, a lot of data are there. I mean, on the anti-resorptives and also the anabolics, and so far only anabolic we have only one drug available, that is teriparatide, is the only one that is available as of now. So as already put up, in those patients with a very high risk of fractures, maybe at a T-score of -3.5 or below, even without any fracture, definitely you can go in for the early anabolic therapy because the fracture risk is high. In other cases, yes, definitely you can consider even if the T-score is minus 2.8 and you're having a spine fracture. Yes, whenever the spine there is a fracture, always anabolic should come into the picture because that gives a highest advantage. And other therapies already put up, we know that we are using the bisphosphonates and even now the denosumab. Only thing with the denosumab might be the cost factor because and also only 2 injections required per year, but the cost factor is the one that comes to the picture. But fortunately now we have the biosimilars available, so that has again brought down the cost. The original molecule usually costs around 25,000 rupees, but the even the biosimilars are only the patient need to pay only half. Yes, so the denosumab is also a very good option, and a lot of trials are there on the sequence therapies, and a lot of data are available. So I would say all therapies are good and effective. Rightly choosing the patient at the right time would be the most important.
So regarding denosumab, there was an article in NEGM saying that once you stop denosumab, the bone BMD falls very rapidly and the fracture risk is very high. Exactly. So is it like it is a commitment for life if you start denosumab to your patients? So
that is the most one of the difficult thing, because denosumab will help you gain faster. But once you stop, I had shown one more slides also. The BTM, bone turnover marker, increases in 1 year time itself, and also the bone mineral density decreases in 2 years time. So that is the one difficult part that we have, and the freedom extension has shown that even up to 10 years of therapy, you are safe with the denosumab. But if the patient is, is not able to continue with that, then again you will have to shift back to the other anti-resortive. That is a common ones, that is IV zoledronate might come back again. So there is a gap that we have, because the life expectancy is prolonged, and you will need multiple drugs at the various stages.
So Dr. Vivek, most practical therapy probably would be zoledronate acid.
Very
yeah. So what dose? 4 milligram, 5 milligrams? This is a question from Dr. Shweta.
So 5 milligram dosage yearly. That is the dose we use. And again, as Dr. Prem has mentioned, that after 3 years, or depending on the fracture risk, after 3 or 6 years, we can reevaluate. We can consider whether to continue or whether we can give patient a drug holiday. Again, we can decide on the basis of bone turnover marker also, that whether patient is okay for drug holiday or not. If patient resorption marker are very low, the bone is into the frozen state, we can consider that the patient may require drug holiday, and we can also monitor during the drug holiday for that purpose.
Most cost effective would probably be the donates that like they follow in the NHS. So basically, I had some patients from US and some patients from NHS. NHS uses a lot of alendronate, because it's probably a good drug, a cheap therapy, can be taken once a week itself, and you have to counsel your patient. That would be it. What about Tibolone? That again was a question from Dr. Shweta. Dr. Prem, what is your opinion?
Yes, definitely. So sorry to miss on that part, because Tibolone is one of the very good drug because of the estrogenic and even the progesterogenic, and also the androgenic benefit. And studies have shown that it is beneficial in those with females complaining of decreased libido and all. This Tibolone is also good. So 20 mg dosage, yes, definitely that is also an option. And but I think infrequently used in our clinical practice.
All right, I'll take briefly the comments on simultaneous versus sequential therapies, and then get back to the orthopedic perspective.
Definitely.
So what is your opinion, simultaneous versus sequential? Even if you look at, common sense would guide that if you want to maintain the BMD with zoledronic acid or alendronate, you can at least increase it first to a decent value and then maintain it over there. And the second way is give the therapies that are anti-resorptive, and if they fail, then you go in for a anabolic therapy. So common sense would say that increase it if cost is not a barrier and the patient is ready for injectable therapy. Once you have achieved a decent value, even if you have given it for 2 years, but you basically cannot use it more than 2 years, so give it for 1 year get it to a decent value, maintain it there with the donate bisphosphonates, and then use it again as required. So what is your opinion? I'll take opinion from Dr. Vivek first. Bisphosphonates, teriparatide, simultaneous sequential bisphosphonate before teriparatide before bisphosphonates. What would be the ideal situation that you like your patient to be in?
The ideal situation would be the starting with the teriparatide, and maybe patient would be taking for either 6 months or 1 year, and followed by we can give it a shot of so that we maintain BMD at that level. Because as already mentioned by Dr. Prem, that if bisphosphonate is given early and followed by if patient is started on teriparatide first, the anabolic effect of teriparatide is little stunted, and therefore better to use if in a high risk patient anti-anabolic agent first, followed by anti-resorptive.
Dr. Prem, bisphosphonates and denosumab.
Yeah, just a minute. Javed, can you kindly please mute yourself? Yeah. So yes, I mean, first again, I definitely agree with Dr. Vivek. I said first anabolic, followed by bisphosphonate to protect it. There was one study also, I mean, where the comparison of which showed, I mean, if you're starting the teriparatide and the bisphos, I mean, zoledronic together, the BMD gain is not that much as you are, I mean, plus as you are expecting. And if you are giving first bisphosphonate followed by teriparatide, that is not going to be that much beneficial at all, rather than starting the anabolic early. Because once you start with the zoledronic acid, it brings down all the, I mean, I can say the bone cellular units will come down. So there will be only less space for the PTS to induce upon the bone formation. So always anabolic first in the situation required, followed by protecting it with the anti-resorptive.
In fact, using a simultaneous therapy, anti-resorptive with an anabolic agent, you basically want remodeling also, because osteoclast would be the cell responsible for remodeling, and it would take into account the shear forces and the stress points. So if you give them together, probably the remodeling would be affected much more. So giving an anabolic therapy first, osteoblast is activated, they're laying down bone. Osteoclasts are still there for remodeling, for looking after the shear forces and the stress points, and then probably after the job is done, the job of the osteoclast is done, then probably you can limit the activity of osteoclast by anti-resorptives. That makes much more sense. So sequential therapy with an anabolic agent followed by anti-resorptive would be making much more sense. Teriparatide, denosumab, we already touched upon that if you have someone who is already being given 2 years of teriparatide, you have no other option, want to give an anabolic therapy, probably denosumab. Coming back to our orthopedician, Dr. Sri Ganesh, if you're audible right now.
Dr. Ganesh?
No, we're not audible right
No,
now.
we are
There's some
not.
problem. Probably we can log out and come back to us again, because you're not audible, or basic login from a mobile device.
I'll just check with him.
Can you hear me now? Hello?
Yeah, great. Now, so basically,
we can hear you, sir. We can hear you.
So what basically we were looking for from you was the indications for surgery in osteoporotic vertebral fractures. We, if getting our patients screened, even if we cannot get a BMD, if we can get a X-ray spine for our patients, they come back to us with anterior wedge collapse, to one or two vertebra. So what would be your suggestion of what patients would you like to be referred to you with the osteoporotic vertebral fracture? All patients, or there are some category of patients that you would like to undertake surgery on for the osteoporotic vertebral fractures?
All right. Am I audible now?
Perfect.
Loud and clear.
All right. Thank you. At the outset, I would say that was an exhaustive pharmacological discussion, a bit of an overdose for an orthopedic surgeon, to be frank. So now coming to the surgical aspects, can I briefly tell you the types of surgeries that we do? Basically, I think everybody has heard about kyphoplasty and vertebroplasty. The AAOS, that is the governing body for orthopedic surgeons in America, came out with a declaration in 2011 based on randomized controlled trials, which said that vertebroplasty has absolutely no role to play in osteoporotic vertebral fractures, because the trial showed that vertebroplasty and non-surgical management nearly had the same role and the same effectiveness as far as 3 months, 6 months, or 1 year were concerned. However, in 2014, they completely reversed that decision and declared that based on a meta-analysis of 6 randomized control trials, that vertebroplasty does in fact reduce the pain in a short-term duration for vertebral compression fractures. So we have 3 forms of surgical interventions. One, we have these percutaneous vertebral augmentation surgeries, or PVAs as we call it. And then we have the osteotomies, which are done to correct the bent up spine. And third, we have the decompression and instrumented stabilization surgeries, which are done especially in the setting of a neurological deficit following a vertebral fracture. So the former surgeries, that is the PVAs or percutaneous vertebral augmentations, are of 2 types. One is we do these vertebroplasties, and the other one is kyphoplasties. Very briefly, this kyphoplasty and vertebroplasty, they just involve inserting a trocar percutaneously within the pedicle of a vertebra, entering into the vertebral body, and injecting liquid or a semi-solid paste of bone cement. In vertebroplasty, it does not reduce the vertebral height. However, in kyphoplasty, we use a balloon which is inflated within the substance or the body of the vertebra, which actually increases the anterior vertebral height after a collapse. And this reduces, in effect, the vertebral fracture. So overall, kyphoplasty is theoretically and biomechanically a better option as compared to vertebroplasty. Now, as far as the indications are concerned, the current guidelines state that all vertebral fractures, all osteoporotic vertebral fractures need to undergo a trial of conservative management for a minimum of 3 weeks. And we can extend it to up to 6 weeks. In case within 3 weeks, their pain and their ambulatory capacity is not improved, that is when we consider them for surgery, especially in the setting of an intractable pain. And there are various scores, the Oswestry Disability Index and the Frankel Disability Index and Visual Analog Scale, which are used to actually figure out the disability status of a patient after 3 weeks. So once after 3 weeks, the patient has intractable pain and the vertebral collapse is more than 20% of the anterior vertebral height, or as the collapse is more than 4 millimeters, the segmental vertebral collapse, that is the indication for a possible surgery. And other than that, we do posterior decompression and instrumental stabilization in the case there is a neurological deficit following a vertebral compression fracture. So in a case when there is no neurological deficit, the indications are limited to only beyond 3 weeks. And 95% of vertebral fractures, according to the studies, do not require any surgical intervention. And in fact, 60% of them are even not painful, they're painless. And patients do not notice it. And we notice it incidentally upon diagnosing for something else.
So is it applicable for just one vertebral fracture, or you have 3 consecutive vertebrae that are fractured? Would you be more interested in operating someone who's got 3 vertebrae or 2 vertebrae consecutive fracture as compared to one who's got an anterior wedge collapse of more than 4 millimeters?
In case of multiple vertebral fractures, we measure something called as a Cobb's angle, which actually indicates the gibbous or the kyphotic angle. In case this angulation is more than 40 degrees, it functionally incapacitates the patient and even reduces the lifespan by 15 to 40%. So under such circumstances, when the Cobb's angle is more than 40%, there is a definite indication for a surgical intervention, provided the other parameters, the ASA, that is the anesthesia guidelines, are amenable to actually anesthesia and surgery.
All right, coming to Dr. Veena again. So HRT and osteoporosis, we did not touch upon this part. We were more of the antiresorptives and the anabolic agents. Postmenopausal osteoporosis, HRT, well, what is your opinion? And its combination with the various therapies that we have discussed already.
The role of HRT is actually it's a preventive measure in prevention of osteoporosis. It's not a therapy actually. The hormone therapy is for prevention of osteoporosis, that is comes under secondary prevention. We get two types of patients, like those patients who undergo surgery for endometriosis or ovarian carcinomas, and where there is surgically induced menopause much younger than the natural menopause. And then we get another group of patients like premature ovarian failure, where they have the menopause much earlier. So in these two conditions, where we have to assess the risk, because the hormone therapy is always associated with much increased risk of cardiovascular diseases, stroke, venous thromboembolism, and carcinoma of the breast. So we have to assess these patients for these risk factors, and then we have to individualize the hormone therapy. And those who are indicated for hormone therapy with no risk factors, we can give the hormone therapy till the natural age of menopause, that is this up to around 52 to 55 years. After that, they can be followed up. And second category of patients is the patients with the uterus, that is the surgically induced menopause. We remove the uterus so that you need not supplement with progesterone. So there are two types of therapies, like estrogen alone or estrogen and progesterone. And we have different type of estrogen, that the conjugates, that is a age-old your conjugated equine estrogen. But the problem with oral equine estrogen is that there is increased risk of venous thromboembolism and stroke in these patients. So we are a little bit skeptical in starting this CE alone. In such cases, now you have got 17-beta estradiol, and it has been proven that in patients who are at risk or mild risk of venous thromboembolism, and indicated cases where they're symptomatic patients, and such patients, you have got this vaginal rings, and also transdermal patches are there. So transdermal estradiol, estradiol creams, that is Evolon cream, and 17-beta estradiol creams are also available, and also transdermal patches. And these are associated with less amount of VTE and a stroke risk. So in such patients where there's no uterus, we choose this therapy, and only after cardiovascular risk assessment, and we ask for family history of other malignancies like breast carcinoma. And then in at-risk patient, we get a mammogram also done, because you have to rule out, and also any other factors. So we do a thorough assessment, then only we start hormone therapy. And without uterus, estrogen alone will suffice. And in those patients with uterus, like premature ovarian failure, we have to combine it with progesterone, because we have already seen that estrogen, unopposed estrogenic action, can cause endometrial carcinoma. In such patients, previously we used to combine it with medroxyprogesterone acetate, that is synthetic progestins, and norethindrone acetate. And it has been shown that the risk of VT and thromboembolism and stroke is much higher when we combine it with progesterones. Now the trend is to combine it 17-beta estradiol and natural micronized progesterones, where the risk of VT is much lesser. Now another combination which is coming up is a combination of this conjugated equine estrogen with besidoxifene, that is the tissue selective estrogen complex. Now this besidoxifene is a tissue selective, means it has got an agonistic action on the bone. It is known to reduce risk of bone fracture, but it has got antagonistic action on the breast and uterus, that is endometrial activity. So it's less likely to develop carcinoma endometrium or carcinoma breast, while giving the benefit for to prevent the osteoporotic fractures. What we do is we give estrogen, and then 1 to 14, that's every month 14 days, or every 3 months 14 days, you have to combine it with progesterone. So that's what we use. And another thing is, there is North American Menopause Society position statement has come in 2017, and the risk benefit ratio, it is more beneficial if you start this hormone therapy in less than 60 years and within 10 years of menopause. We get another group of patients which we get is coming with vasomotor symptoms, and this prevention of vasomotor symptoms you can't get with any other non-hormonal therapy except replacing with estrogens. So such patients, if they are less than 10 years of menopause and less than 60 years, there is maximum benefit and the risk reduction is much lesser. But after 60 years and after 10 years of menopause, the risk of VTE and stroke has been found to be much higher. So we are a little bit skeptical in starting hormone therapy in such patients. And moreover, it has to be individualized. We have seen that in carcinoma patients also it is not contraindicated. In carcinoma breast also we can select tissue protective, that estrogen complex. And in carcinoma ovary, where the estrogen receptor, like serous carcinomas, advanced carcinomas, or endometrial type of carcinomas, except for that, germ cell tumors are not a contraindication for hormone therapy. So also cervical, vaginal, vulvar carcinomas, where they don't have any hormone receptors, in those patients also, if indicated, you can give hormone therapy. That's how we manage. So it has to be individualized, and risk assessment should be done, because hormone therapy is always associated with complications. Thank you.
So, Dr. Vivek, bisphosphonates, already discussed a lot on that. Which one and when do you plan that's individualized therapy again? What about the renal dosing? If you have a patient in EGFR of 45, for example, what would be your choice, and how would you dose it renally?
Majority of patients with EGFR of more than 30 or 35, they don't require any dose modification, especially with either alendronate or zoledronate, even IV bisphosphonate. The dose modification is not required. However, the risk of hypocalcemia is quite significant in this kind of patient, and therefore the adequate calcium and vitamin D supplementation has to be ensured before giving bisphosphonate in the renal patient.
How would the risk of AKI with zoledronic acid versus, for example, oral drugs like alendronate and nabandronate? It's somewhat higher with zoledronic acid. Do you agree with that?
Yes. There are data that suggest that with IV zoledronic acid, the risk of acute kidney injury is higher as compared to the oral bisphosphonate, and therefore choosing bisphosphonate, especially in this kind of patient, is very, very crucial.
So drug holiday, Dr. Prem discussed that high risk versus low risk. It will depend on whether your patient is a high risk or a low risk, and somewhat to the response to therapy also. If your patient has responded well to therapy, probably you can give a drug holiday earlier. If has not responded, probably you'll have to change therapies, get a combination, and then probably you can give a drug holiday. Then is commitment to life. We already discussed that. The NEGM paper said that. Coming back to Dr. Sri Ganesh, we already had a word. So all patient already had a fracture. You fixed it surgically. What would be your advice to that patient for secondary prevention? Your perspective on that?
Hello. Well, I think the prevention of osteoporosis has been quite exhaustively covered by Prem, and my options would not be very different from that. However, I would like to emphasize on fall prevention guidelines, which have been released by AOS as well as NHS, and there are some very simple aspects to it, such as whenever there is a patient with a vertebral fracture, you want to mobilize him, and we start physical therapy. One important advice to be given is to avoid all forms of flexion exercises, because we leave it to completely to the discretion of the physical therapist, and oftentimes we find them coming back with a second fracture. That is because flexion related spine exercises are known to increase the risk of spinal fracture by 40% in comparison to extension exercises. So we would emphasize on spine extension exercises, prone raises, quadruped exercises, and so on. That is number one. Number two, there are simple fall prevention guidelines, such as removing home hazards, anti-skid mattresses at home, and hip protectors. There are these hip protectors which are known to prevent hip fractures in an osteoporotic patient. and a well-lit environment, simple ergonomic changes to their working place or their living space. That will help. And apart from that, I would say the pharmacological therapy in my setup, we start vitamin D prophylaxis and calcium, and a combination of these clearly, because that is superior to using either one separately. And apart from that, I would go on to start bisphosphonates. The most we have started would be teriparatide, and that would be my knowledge with respect to pharmacology. So
a lot of orthopedic colleagues come and ask us, the PTH is like, do you have a cutout for PTH that we want to start PTH therapy for? Dr. Prem, do you have an answer for that?
No, this was a one. I mean, question. I have. I mean, even many of the international experts also I used to ask us in our one of the meetings and all. So I think the upper limit. I mean, they were telling like some had told that. I mean, if it is 70 and above, they will be skeptical about starting. And Vellore guys, I know even I have discussed with them also. So they were like 100 or above, they will be skeptical about starting. So I think the upper limit of 65 to 70 above can be a reasonable, above which I mean correct the vitamin D and repeat it and see, and if once it's down you can below they can start with that.
We have a question from Dr. Amit for Dr. Sri Ganesh, I guess. When do you start therapy for hip fracture after surgical intervention? Any medical therapy that you want to start, when would you be very likely to start a therapy after you have intervened surgically in a hip fracture?
Ideally, I would start it immediately after the surgery or as soon as the diagnosis is made, because I don't think it makes much difference to delay it. And the therapy I would start would be a combination of calcium, vitamin D, and bisphosphonate. That is the pharmacologically.
So a very important point that you have put up, basically, for apart from the pharmacological therapies, decreasing clutter in the house of patients who got osteoporosis, putting on bands for them to catch hold of in washrooms, for example, adequately lighting the washrooms, and the paths that they take from the bedroom to the washroom, and using anti-skid mats, really, not to bolt the washrooms for patients, would be the advice that we would be giving to all our patients. That is also very, very important. That has to be given to each and every patient that we have to prevent a fracture, because once a patient has a fracture, the mortality increases very rapidly. The slope of mortality increases very rapidly after one hip fracture. So thank you very much. I guess we had a very interesting discussion, a very exhaustive one also. We had some surgical aspects of from the orthopedician that we probably did not know, and he also must have benefited from the medical therapies that we had to offer, the discussions that we had to offer. I'll hand it over to Dr. Amit Rastogi for taking it over from here.
So thank you, Dr. Saket, and it was really an academic feast for all of us. And as I was mentioning that it was probably for the first time to be a part of such a galaxy of speakers and from different fraternity, that is they are dealing with osteoporosis. It's a great learning, I would say, nothing to shy about. From that, nothing, Dr. Beena ma'am gave her opinion regarding the HRT issue. It has to be individualized, new molecules coming into play. And Dr. Sri Ganesh taught us that just not abide to the medical therapy, but patients have to be referred to him depending upon the degree of fractures. So thank you so much, everyone. The panelists, Dr. Vivek from our fraternity has shown a lot of insight into it, and I think that everyone have gained from it. And I think that I will hand over to Dr. Prem now to give a vote of thanks to all of us. He was the brain behind this symposia. Thank you so much, Prem.
Yeah, thank you, Amit sir. So once again, thanks to all of you for being a part of this very wonderful program. And I would start with my madam teacher, Professor Veena madam, for completely, I mean, straight away agreeing to be part of this meeting. There's a multidisciplinary osteoporosis, and I just called madam. I think I completed my internship in 2008, and after that only this time only, I mean now only, that's after 12 years I called madam. And to be frank, during the internship days also, we were very, very much afraid of madam. Madam was very strict in the internship, I mean labor room days and all. So thank you so much, madam, for being part of this program. And we had a lot of insight from you on the HRT and the gynecology
Thank you, Prem.
perspective
Thank you, Prem,
osteoporosis.
because it was great learning from the student also. Thank you so much.
Thank you, madam. And then next we move on to our next expert panelist, Dr. Sri Ganesh, my colleague. He takes care of our ortho department, and thank you for your insight on the surgical perspective. And so thank you
Thank
for
you, Prem.
being
Thank you
part
for
of
the
the
wonderful
program.
feast.
Yeah. And next, my senior again, Dr. Vivek Patel, and from BHU days, we are continuing on, and we are still on with the WISDEN together. And thank you again for being part of this wonderful discussion and wonderful meeting. And we hope we will continue again more in the future. And next, we have had two speakers also, Dr. Padmanabha Shenoy, the rheumatologist, well-renowned rheumatologist from Kerala. And he also gave a wonderful lecture. And apart from that, Dr. Arun Philippe, again, he was also my senior in Kottayam Medical College, and he also had a wonderful discussion on the osteoporosis in malignancy. And above all, again, we have I have two important persons to thank with the president of WISDEN Society, that is Dr. Saket Kant, and well moderator. I mean, he's a master at this. His moderating skills and also speaker skills. We'll be seeing that in further programs. Maybe another multidisciplinary with the gynecology, that is MHT, and all are open topics. We can have madam again in the future. And so thank you, Dr. Saket Khan. And again, our senior, again, Dr. Amit Rastogi, always there up front for all academic meetings together, and very important member again of the Executive Council of WISDEN Society. Thank you, sir, for being part of this program. And last but not the least, and we thank the team INTAS headed by Mr. Javed, Durai, and also Rupesh for giving us, coordinating with us. It's not an easy task to coordinate. We have almost five departments together in a meeting. So thank you all for coordinating with us, and thank you for providing the platform for the discussion of this academic feast. And before I conclude, I think I have included everybody, and just handing over to Javed for his words of closure.
Thank you. Thank you. And good evening once again, Dr. Prem sir, for giving us this opportunity to be associated with you. It's often said that osteoporosis is a silent disease, but we should not remain silent about it. And this particular webinar has clearly proven that today we got a lot of wisdom regarding osteoporosis, medical management, and also surgical intervention from a multifaceted galaxy of speakers and a multidisciplinary approach towards the program. So though Dr. Prem sir has already thanked everybody, but I would like to personally thank, because it's been a wonderful program, though it has been there for 2.5 hours, but nobody really felt that it is actually a lengthy kind of a program, because there was so much of insights that we could get in terms of improvising and making a great value addition to our clinical, each other's clinical practice. Dr. Amit Rastogi sir, Dr. Saket Kant sir, in fact speakers Dr. Prem Narayan sir, Padmanabhan Shenoy sir, Dr. Arun Philippe sir, and expert panelists Dr. Binna madam, Dr. Vivek sir, and Dr. Sri Ganesh sir. So I would like to personally thank you from my side for taking your time to sharing your wonderful work on this osteoporosis, a multidisciplinary approach as well. From the company's point of view, I would just take another 2 minutes to share with you certain things related to the treatment aspect and the drugs, what we have been doing for the last 10 years in osteoporosis management. In 2004, I was associated with Eli Lilly company, and I launched teriparatide in the country. At that time, it was costing 20,000 rupees for 1 month. 16 years before, 20,000 rupees for 1 month, you could know how many would actually afford that particular thing. 6 years after that, in 2010, I launched India's first biosimilar teriparatide with Intas. At a reduced cost, which was almost half. And today, in fact, I'm very happy to share with you that after 10 years of building bones and improving the quality of life of osteoporotic patients with your valuable patronage and support, And in this pandemic time where the cost is actually becoming a very big limiting factor in terms of chronic therapies, I'm very happy to share with you that because of our indigenous manufacturing and looking at the scope for further usage of this molecule, Terifrac we have reduced down the price of Terifrac, and it would be costing now 3,000 rupees per month. It's available in a pack of 6 at this particular rate, which means a pack of 6 would be available at 18,000 rupees. Why I said 18,000? Because in 2004, we launched teriparatide with other company, it was 20,000 for 1 month, and now you could see for at a lesser cost than that 1 month, the patient can be benefited with 6 months of therapy. So this is something which I'm sure you would appreciate from Inta's side. Second thing is, all the speakers did mention about bone turnover markers, which is actually one of the way of monitoring osteoporosis treatment. But let me share with you, with my 16 years of being in this field, monitoring still continues to be a very, very gray area, not only India, but globally, because disease is of that particular thing. But for a bone formative markers, it's still costing. I mean, it's costly in terms of probably getting it done for the patient. So I am very happy to share with you that for every patient whom you recommend teriparatide, we would be doing a bone formation marker test, P1NP test, which has been discussed already at baseline, that is at starting the therapy, and after 6 months, because within 6 months you could see the tangible benefits of teriparatide in terms of increasing, I mean, the rate at which the bone formation has been there. So we will be doing this free of cost, both the test, and subsequently also you want it to be monitored after a year, 1.5 years, because it can be given for a maximum duration of 2 years, and DEXA cannot be repeated before 2 years. So this particular benefit from the company can be passed on to your patients as well, and is going to be done free of cost. We have associated All India with Lal Path Labs and my colleagues there in your respective places, and wherever the speakers are from, either Delhi, Meerut, or Chennai, Cochin, Chennai, it is a pan-India. This service is available to all your patients. And third, I would like to share with you that we have made our treatment basket more comprehensive in terms of osteoporosis by launching world's first biosimilar denosumab, which Dr. Prem sir has already mentioned. And the cost of denosumab also has come down by half, which is the benefit of probably launching a biosimilar as well. So that is also available for your patient's benefit. And adding on to that, there has been a lot of innovation that we have been doing in terms of our products, in terms of our services, so that your osteoporotic patients can be better and their quality of life can be enhanced. Let me share with you that all the biosimilars in the country today are available at 750 mcg in 3 ml. So each ml contains 250 mcg, but the dosage per day for teriparatide is 20 mcg, which is actually the patient requires only 600 mcg. The additional 150 mcg is there for priming the pen because it was a reusable pen. And let me jump the gun and take away the surprise from my colleagues, because they were about to bring to you in the first week of December. But since this is a wonderful program, I just thought probably I can share that with you. That first week of December, we are going to be launching another innovative product, first time in the country, and maybe in a world also, world-class disposable teriparatide pen with the formulation of 600 mcg in 2.4 ml. So this is going to be available to your patients. Right now, we are launching it in singles, and subsequently we will enhance it in the combi packs of 3s as well as 6s. So this is probably our journey that I have shared with you in a nutshell. What we have been doing in the last decade or so. For me, it is both been with innovator as well as with biosimilar, and that's why I have not missed 5 minutes of any of this 2.5 hours talk. And anytime we are there with you in terms of making a valuable partnership with you in terms of creating more awareness about osteoporosis among healthcare providers as well as patients. So you can always give us an opportunity like how you are given it today. Thank you very much once again for a wonderful webinar. I leave it to Dr. Prem right now, probably to conclude the meeting.
So, yeah.
Thank you very much, sir.
So thank you all once again on behalf of WISDEN and also the Ahalya Diabetes Hospital. And stay safe and good night.
Stay safe. Yes, yes, all of you. Thank you very much. Stay safe and stay healthy.
Thank you
very
Javed,
much
for
sir.
the information.
All right. Good night. Good night.
Thank you,
Good
Prem,
night.
sir.
Good night.
Yeah.
Good night
Thank
and
you.
take good care of
Okay, thank you.
yourselves, all of you.
Durai. Bye.
Thank you, sir.
Thank you. Bye.
Thank you, sir. Thank you so much.
Thank you.